So very good morning everyone. Welcome to the FMGE Lab 2 and this is the first subject we are starting with. We are starting with psychiatry. This is Dr. Ankit Goel, your psychiatry faculty. Quickly let me know in the chat box but if I'm audible and visible to all so that we are quick to go. Right, so we'll be covering all the important high topics of psychiatry for the upcoming FMG exam. Very happy to see all of you. A very good morning to all of you. So what we are going to do, we are going to discuss psychiatry. Now, as I always say, beta, psychiatry is a very time efficient subject. You know what we mean by time efficient. So we have talked about psychiatry in our classes as well, and now we're going to revise. You will see that from the topics which we are going to cover today, you will see lots of questions being asked in your exam. In fact, nowadays you will see nearly 10 plus questions are also have been asked in the exam, in the FMG exam from psychiatry. Now we're going to learn lots of concepts. We'll not mug up thing. I'll bring cases into the class so that you understand how a psychiatric patient presents to us, how the examiner is asking question. We'll also use lots of fun ways and mnemonics I'll give you. So Shakespeare has said what's there in the name, but I always say names are very important in psychiatry. But you just remember the name and I'll help you understand and remember the concept. So we'll use lots of these ways so that we can not just understand but we can also remember things. Also we are going to discuss some latest MCQs, but all the MCQs which have been asked in the recent exams, we'll try to cover those as well so that you have an idea how they've been asking question. And a very important part of our classes beta which I say is the FQs. So FQs are future question. We'll discuss some question. I'll tell you they may come as new question. In fact, so many questions previously which we have predicted have come in the exam as new questions. So we'll discuss all those points as well. So how we have planned, we'll take a break after every 2 hours, and as I am being told that it is divided into beta 2 parts today's class of psychiatry. Part 1 that will be before the lunch break till 2 o'clock. It will be available both on the YouTube as well as in the app, while the part 2 which will be available on the app itself. So those who are not joined the app, you can always go and see the course as well. So let's begin. I hope all of us are ready. So let's begin the session. In fact, you know, before beginning I always say this, but since we are starting lab 2, it's very important to understand this. You still have plenty of time. It's very important to focus on one day at a time, and you will see small steps every day, small efforts every day will ultimately accumulate to big success one day. So with this message, better let's start the session, and these are the important topics which you're going to cover in today's session. So let's start day 1. I hope all of us had a good breakfast. So let's start day 1. I hope all of you are ready. Right. So let's begin. But let's start with the basics of psychiatry. In fact, you will see in nearly all the exams, you know, many questions have been asked from this basics. So let's start with the basics. But the term psychiatry is coined by two Greek words. Psyche means mind and itry means healing or cure. So it's a branch of medicine which deals with problems of the mind and its cure. Can you tell me who coined the term? Who coined the term psychiatry? Those who are in the app as well as in the YouTube, beta, can you tell me who coined the term psychiatry? Remember, the term psychiatry was coined by German physician with the name Johann Christian Riehl. A very important old MCQ. So the term psychiatry was coined by Johann Christian Riehl. So let's start with the first. Very good. Let's start with the first and very important topic. Beta, this is very important. MSE, that is mental status examination. So when we are examining, beta, जब हम एक psychiatric patient को examine कर रहे हैं, one of the important examinations which we do is the mental status examination. Also, you can appreciate from the name, we are examining the mental status. Also, please don't confuse this from MMSE. Beta, what is MMSE? I hope you remember what is MMSE. It is mini mental state examination. It's a screening tool which we use to assess cognitive functions. Like when we assess patient with dementia, we apply some scales, and one of the tools is MMSE. So please don't confuse MSE with MMSE. Now also very important, but nowadays anything which is trending, you know what we do, we put a hashtag. So anything which is very important, I'll place a hashtag. So when you're revising in the end psychiatry, please at least revise those important topics. So let's start with MSE. A patient comes to the psychiatry OPD, our examination has already started. So the first important heading which we're going to cover in the MSE is mood and affect. Now both these terms, beta, mood or affect, ये क्या करते हैं? They describe the emotional state. But there are important differences. Let's understand कि mood और affect में क्या difference है. Now mood is a persistent and pervasive emotional state. Beta, that it's an emotional state which is persistent. What do you mean by persistent? That is, it is present most of the time. So let us say a 40-year-old female comes to the clinic and says, sir, for the past 2 months, whether it is morning, sir, whether it is afternoon, whether it is evening, I am feeling sad. So can I say जो sadness है, जो emotional state, it is present most of the time. And pervasive means it is present most of the places. So this female says, sir, wherever I am, whether I'm at my home, whether in my office, sir, whether I'm in a shopping mall, whether I'm in a kitty party, I am feeling sad. So can I say that that sadness, that emotional state is persistent and pervasive? So that is her mood. But tell me, mood is a internal phenomena, but ये internal phenomena या ये external phenomena है? What is mood? Very important, but remember, mood is a internal phenomena. It is something which the patient is feeling from within. Patient अंदर से महसूस कर रहा है ना sadness, that is mood. Then what is affect? But affect is very good. Affect is expression of emotions. Our emotions, beta, they are expressed in our face, in our body language, है ना? Sometimes it happens कि आपके friend, आपके family member ने आपको कुछ नहीं कहा, but आप उनको देखते हो and you see, अरे what happened? Why are you feeling so sad? Why didn't you take anything? So they have not said anything, बेटा उन्होंने कुछ नहीं कहा, but उनको देख के आपको लग रहा है that they are feeling sad. So this is affect. Affect is something which is observed by the doctor, observed by the therapist. So tell me, affect is internal or external phenomena? Of course, you will say very good. Affect is a external phenomena. Now let's discuss some important abnormalities of affect. But this table is very important. Let's now focus on some important abnormalities of affect. The first important abnormality we'll discuss is flat affect. Again, don't mug up anything. See, when we do ECG, you see such waves on ECG. How is the ECG of a person who is dead? It's a flat line. Also remember, flat affect also sometimes referred to as blunt affect. So this is the meaning of flat affect, as if the emotions are dead. There is no change in the emotion. So please see this. This may be asked in the exam. We are discussing, some sad moments of patient's life. Let us say recently some family member died in his family. तो बेटा मैं पेशेंट से बहुत सैड मोमेंट्स डिस्कस कर रहा हूँ उसकी लाइफ की, बट द पेशेंट इज लुकिंग लाइक दिस. देयर इज नो चेंज इन द अफेक्ट. नाउ लेट अस डिस्कस सम हैप्पी मोमेंट्स ऑफ हिज लाइफ. लेट अस से रिसेंटली वो प्रमोट हुए थे, रिसेंटली बिकेम अ फादर. तो मैं उनकी लाइफ के कुछ हैप्पी मोमेंट्स डिस्कस कर रहा हूँ पेशेंट से, बट द पेशेंट इज लुकिंग लाइक दिस. There is no change in the affect. Can you appreciate? मैंने happy stimulus I gave sad stimulus, but there is no change in the affect, as if the emotions are dead. So this is known as flat affect. Can anybody tell me where it is seen? Very good, beta. It is seen in a very important condition, schizophrenia. So please remember, we'll discuss. In fact, can you tell me it is which symptom of schizophrenia? Very good. It's a negative symptom of schizophrenia, which was recently asked in your exam. So it is a PYQ. So you will see a lot of such questions may be asked. So this is flat affect. Again, they may also give you a clinical scenario and ask you what is this abnormality. Now just opposite of flat affect, beta, we'll discuss is labile affect. Now what is the meaning of lability in English? Lability means something which is rapidly changing. So labile affect is rapid and abrupt changes in the emotion. Now again see this situation. Let us say I am talking with a patient, beta. I have not cracked any joke. Patient ने कोई joke crack नहीं किया. हमारे आसपास nothing funny has happened. But the patient starts laughing. Within few seconds he starts crying. Again he starts laughing. Can you appreciate, beta, such rapid and abrupt changes in emotion? You can draw it like this. This is known as labile affect. Can you tell me two important conditions where you can see? Very good. One of the important condition is mania. Very good. Beta, you call it mania or bipolar disorder. I'll take both the answer. Any other important condition? Very good. Second important condition which we will discuss is organic mental disorder. A very important topic. This has been asked in your exam. This topic we will cover as the first disorder where we will start the disorders. So these two are very important abnormalities, but since we are discussing better abnormalities of affect, let's complete this table. Let's discuss two more abnormalities. One is inappropriate affect. Very good. Can you tell me better what is inappropriate affect? As the name suggests, that the affect is not appropriate, or you can say that the affect is not matching with the situation. So affect is not appropriate with the situation. So one example beta which we always discuss. So suppose a person goes to a funeral, everybody is very sad, somebody died in the family. He goes to the funeral, he sees the dead body and he starts laughing. Can you appreciate that his affect is not matching with the situation? This is inappropriate affect. Can you tell me one important condition where? Very good. Where it can be seen, beta? You can see inappropriate affect in conditions such as schizophrenia. Very good. I'm very happy all of you are answering correctly. inappropriate. Beta, let's finally also discuss what is incongruent affect. See, congruent का मतलब है to match, in sync. Incongruent means that the affect beta is not matching with the mood or the thoughts of the patient. See, usually it should match, like a patient who is saying I am feeling sad, so his mood is sad, and when you see the affect, beta affect भी sad है, depressed है, तो match कर रहा है. But again, let's see one example. You ask a patient, see here everyone, you ask a patient how is your mood. See what the patient says. Patient says, sir, my mood is very sad. My mood is very sad. Can you appreciate beta here? He is saying that the mood is sad. But what was the affect of the patient? You are seeing that the affect is very happy or it is euphoric. So can you appreciate that the mood and affect are totally opposite, they are not matching. So this is incongruent affect. Or the patient is having sad thoughts and the affect is happy. So this is incongruent affect. Again, can you tell me beta? Very good. Where it can be seen? It can be seen in conditions such as schizophrenia. Very good. Beta, please see this table again. You may get direct or indirect questions from this table. So very, very important. Let's also discuss, since we are talking about the emotions, let's discuss few more questions from this topic. But let's discuss one important term. I hope this is clear to everyone. Again, I am saying please put a hashtag. It's a very important topic. You may get questions from this table. Let's discuss, better, since we are discussing emotion, let's discuss some more points about this topic. So let's talk about beta what is anhedonia. Again, this question was asked in your FMGE 2019 exam. So sometimes they may just ask about the definitions also. So you should know all these phenomena. Beta, what is anhedonia? Very good. Anhedonia is decrease or loss of interest. Patient was having pleasure, was having interest in activities before, but now he's saying, sir, I have lost interest in those activities. Like that 40-year-old female says, sir, earlier I used to enjoy doing shopping, but nowadays I have lost interest in shopping. I have lost interest in going to my office. So beta, ye kya hai? This is anhedonia. Can anybody tell me beta two important conditions where you can get or where you can see anhedonia? First, very important beta, we will discuss in depression. So we will discuss a mnemonic to remember the symptoms of depression, and we will learn that there is one important symptom, decreased interest. Can you tell me one more important condition beta where you may find anhedonia? Please remember, very good beta, even in schizophrenia we will learn that yes, anhedonia may be seen. And can you tell me it is what symptom of schizophrenia? So anhedonia beta, it is which symptom of schizophrenia? Remember, it is again a negative symptom of schizophrenia. So we have discussed two negative symptoms already. One is affective flattening or flat affect, and second is anhedonia. Also, let's correlate. But what I'll do is I'll also try to integrate some other subject like basic sciences. Also, psychopharmacology would be a very important topic of discussion today, and also some relevant clinical subject. Jahan pe bhi relevant hoga, we'll discuss. We'll try to integrate. So let us discuss some anatomy, neuroanatomical structures. Now, suppose they may give you a psychiatric question, and in the end they may just ask you the areas involved. So can you tell me which of the areas of the brain beta it is related with generation of emotion? So you are watching, let us say, a movie Animal in the cinema hall, and from within you are feeling very angry. So where the emotions are generated? Very good, it is the limbic system. Very good, it is the limbic system. But you are in the cinema hall, you are able to control your anger. So which area, or I'll give you a clue beta, which cerebral lobe is related with regulation of emotions? Which cerebral lobe is very important in psychiatry? Beta, kaun sa cerebral lobe hai? Very good, yes, it is the frontal lobe. Very good, it is the frontal lobe. Yes, yes, Dr. Anubhav, it is frontal lobe. Very good. Also, let's discuss here only beta, I've given you one table. Let's discuss one important point about frontal lobe. In fact, beta, if frontal lobe is affected, sometimes you will see some important phenomena which can occur in the patient. So this may again come as a question, like a patient had a head injury and his frontal lobe is involved, and patient may present to us with some important findings. So can you tell me beta, if frontal lobe is affected, like we have discussed even in Pick's disease, frontotemporal dementia. So what all important points or what all important features may the patient present to us with? First is you can write down beta, personality changes. The personality of the patient may change. So we'll discuss beta what is personality when we discuss personality disorder. So personality basically means how we deal with day-to-day situation. So family members may tell you, sir, inki personality change ho gayi. He's not the same person as he used to be. Also, the person may develop disinhibitory behaviors. So person may develop disinhibitory behaviors. Now usually we have certain inhibitions beta. For example, let us say we are sitting in a classroom and one of us wants to dance. ऐसा तो नहीं है ना, you'll stand on the table and start dancing. No, of course you'll wait for the class to get over, then you'll go in a party or in your house and you'll dance. So we have some inhibitions. But beta agar frontal lobe is affected na, these inhibitions are lost. So this is disinhibitory behavior. For example, the question may be asked like this, कि a person goes outside and starts urinating in public without any guilt. Which area is affected beta? So it is the frontal lobe. And of course, as you can see here, we've already discussed that frontal lobe regulate भी करता है emotions को. If frontal lobe is affected, there may be dysregulation of emotions. So the person may be crying, laughing without any reason. Patient may appear apathetic. So such findings can occur. So please here only, please write down here, put a hashtag here. So such questions may be asked. So we have discussed a very important topic in the MSc beta, that is mood and affect. I hope it is clear to everyone. Very good. Let's now discuss the second and very important topic in the MSc beta, that is the thought. Again, you are seeing nearly 1 or 2 questions beta always being asked from this topic of thought. So we are now trying to understand कि patient की thinking में क्या abnormality है. And as all of us know, हमने abnormalities of thought को बेटा 4 domains में we have divided. One is flow or stream. But just like water flows in a river ना, similarly thoughts are flowing in our mind. तो पहली problem किसकी हो सकती है? Of this flow. Second, we'll discuss problem of content. Content का मतलब है whatever the person is thinking, the problem is in the content of his thought. Third, we'll discuss, slightly tricky, we'll discuss beta what is form. So form means structure or organization. बेटा जैसे ये पेन है, I am holding, इसका एक shape है, एक structure है ना. Similarly, हमारे thoughts also have a structure. When that is affected, then we say it is abnormality of form. And lastly, we'll discuss abnormality of possession. So let's start with the first important abnormality, that is flow or stream. But just like water is flowing, so there is problem in the flow. So the problem can be in the speed or problem can be in the continuity. So let's discuss beta when the speed is affected. So as you can appreciate beta, speed increase हो सकती है and speed can also decrease, है ना. So speed increase का मतलब है in the mind of the patient the thoughts are coming very fast, one thought, second, third, fourth, fifth. So can you appreciate how will be the speech of the patient? Patient will also speak very fast. Okay, so one important abnormality beta which we'll cover today, very important, is flight of ideas. See, again don't mug up anything beta, just see the name. Flight of ideas, the name is telling you as if the ideas are on a flight. That means the thoughts are coming very fast in the mind of the patient. So thoughts are following each other rapidly, one thought, second, third, fourth, fifth. So you ask a question to a patient, the patient may start talking very fast and patient may say a lot of things beta which may not make much sense. And tell me ultimately क्या patient आपका question का answer करेगा? Will the patient answer your question? Tell me, is the goal reached or not? Very good beta, yes, the goal is not reached. This is flight of ideas. But very interestingly you will see in flight of ideas patient is speaking very fast, patient may say things not making much sense, but you will see that his thoughts may be connected somehow. So how the thoughts may be connected? One such connection may be by chance connection. So one thought is connected by other by chance. So it is just by randomly it is connected. For example, a patient speaks like this, my name is Virat, I like playing cricket. Cricket is a game of gentlemen. Gentleman is my friend Mukesh. Mukesh smokes cigarette. Cigarette causes cancer. Cancer is my zodiac sign. So can you appreciate one thought is connected by other by chance. ये मौसम की बारिश, ये बारिश का पानी, ये पानी की बूंदे, तुझे ही तो ढूंढे, something like this. Or the thoughts may be connected by beta what is known as clang association. Beta what is clang association if I ask you? So the thoughts may be connected by rhyming words. So for example, a patient speaks like this, Ram can sing, birds have wing, I am the king, phone goes tring tring, the weather is spring, bring 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 bring. So this is clang association. So this is flight of ideas, but a patient is saying things very fast, not making much sense, the goal is not reached and you will see some connection. Finally, can you tell me, very good, can you tell me one important condition beta, can you tell me jahan pe you will see flight of ideas? If I ask you one condition, please remember we will discuss this point again in mania. When I will discuss the symptoms of mania, in that mnemonic we will discuss one letter F, that is flight of ideas. So but in flight of ideas the speed is increased. Let's discuss when the speed is decreased, and one important abnormality that we will discuss is circumstantiality. See, as the name suggests, circumstantial means patient is giving unnecessary detail. So here what is happening, see, first of all, the thoughts are coming very slowly in the mind of the patient, and the patient is giving unnecessary trivial information, but वो information which you have not asked for. He is saying those things, those details which you have not asked for, but ultimately he answers back your question. So tell me, goal is reached or not reached? Very good, beta. Remember, the goal is reached. So you can again draw this diagram, beta. Suppose somebody wants to go from A to B, rather than going straight, the person is going like this, giving unnecessary details and ultimately reaching the goal. Again, yes, of course, it can be seen in conditions such as schizophrenia and in so many other conditions. Now again, as one example, beta, which we always discuss, suppose you ask a patient, who is your favorite actress? So very simple direct question you've asked. The patient is speaking slowly and the person may starts like this. Sir, Alia Bhatt acts very well. I have seen all her movies. I was upset for a few days when I heard she's getting married, but may God bless her. Even Katrina Kaif is a wonderful actress. I have seen many of her movies. I was upset for a few days when I heard she's getting married. May God bless her. Even Kareena Kapoor Khan is a wonderful actress. I have seen her movies starting from Refugee. I was upset for a few days when I heard she's getting married. May God bless her. My favorite actress is Kiara Advani. So can you appreciate? So person has given unnecessary details, beta वो details जो आपने पूछी भी नहीं है, and ultimately he has answered back your question. But please see, if they don't mention in the question that the speed is increased, but still will you be able to differentiate between these two conditions? I'll discuss some MCQs also, beta, which have been asked in the exam. So can you appreciate, in flight of ideas, patient is saying a lot of things which are not making much sense, and ultimately the goal is not reached. While in circumstantiality, you will see that patient is saying things which are meaningful, but those are unnecessary, those are trivial, and ultimately he is answering back your question. I hope this point is clear to everyone. Beta, in fact, let's see one question, beta. Let me see if you can answer this question. I'll come back to this question again, but let me see if you can answer this question. It is a PYQ of the FMG exam question, beta. Patient says home is sweet, sweet in diabetes, diabetes, urine has smell, smell is hell. You have to tell me what is this phenomena. But again, can you appreciate here, they have not mentioned the speed. Speed is not mentioned now, but still can you tell me what is the right answer according to you? Very good, beta. Can you appreciate, patient is saying a lot of things, not making much sense, but you can see home is sweet, sweet in diabetes, diabetes, urine has smell. So there is by chance connection, and also in the end you will see some rhyming also. So yes, very good, it is flight of ideas. So please be very careful when they ask such questions. Okay, let's come back to this table. So we were talking about beta flow or stream. In this we have covered some important abnormalities of speed. Let's also discuss an abnormality of continuity of thought. So continuity means the thought is not continuously flowing. There is some problem in the continuity. One important abnormality, beta, which we'll discuss, very important, again you can highlight this point, that is perseveration. You can write an FQ here. Perseveration. Beta, what is the meaning of perseveration in English? Somebody is perseverating. There is perseverance. Repeating again and again. A thought persists beyond the point of relevance. So 3 P's you can remember. P for beta perseveration. एक thought है जो patient के mind में बार बार persist कर रहा है beyond the point of relevance. मतलब initially it was relevant, but now it is getting repeated again and again, and it is not relevant anymore. So very simple example, beta, which I always discuss. You ask a patient, what is your name? The patient says, my name is Mukesh. It is correct, it is relevant. What do you do? My name is Mukesh. Where do you live? My name is Mukesh. What is the name of your wife? My name is Mukesh. Now can you appreciate, initially this thought, my name is Mukesh, was relevant, but now it is being repeated beyond the point of relevance. Beta, can you appreciate, as if patient is stuck on one answer, and patient आगे नहीं बढ़ पा रहा, he is not able to go forward. So there is problem in the continuity of thought. So this is perseveration. Any Avengers fan here, beta? What is your name? I am Groot. What do you do? I am Groot. Where do you live? I am Groot. So this is perseveration. Also, can you tell me, very good, beta, also can you tell me 2 important conditions, beta? Also remember the order. First, one condition, beta, if they ask you remember, then you can say organic mental disorder. Also remember, it can also be seen in schizophrenia. But sometimes what happens, patient may just repeat the last word or the last syllable of the sentence. For example, a patient is saying, I want to go home, home, home. Can you appreciate what is this, beta, what is this phenomena again? I want to go home seems to be relevant, right? But now he is repeating the last word again and again, home, 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 home. So again, this is an example of perseveration. I hope this is clear to everyone. Very good. So this is the table, a very important table of beta abnormalities of the flow or stream. Let's now discuss the second important abnormality of thought. But I hope everybody is clear with this now. Just let me know in the chat box if it is clear. हाँ बेटा, he is asking about the toy again, but same question. Yes, then it is perseveration beta. Yes, then it is perseveration. Now let's discuss a very important topic, and this is one of the certain topics in your exam. Usually in every exam we are seeing questions from delusion. So please remember, delusion is an abnormality of thought. So this question was asked in FMG exam beta, that delusion is an abnormality of, it's an abnormality of thought, perception, memory or cognition. So please remember, it's an abnormality of thought. Under thought, it comes under content of thought. Now what is the first point beta which we always write? But I'll repeat that question again. Patient is saying, I want to go home. So that is relevant, but again he is repeating the last word again and again. I want to go home, 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 home. So again, this is an example of perseveration. But a delusion, please remember, it is which symptom? It is a psychotic symptom. So please remember, but it can be seen in psychotic disorders like schizophrenia, and even in other condition it may be seen. So remember, delusion is a psychotic symptom. And what is delusion? It is a false, fixed, firm idea or belief. So patient ke mind mein beta a thought has come, a belief has come which is false, and it is beta fixed in the mind of the patient. For example, a 20-year-old male is brought by the parents in the OPD, and this 20-year-old male beta ye claim kar raha hai that the neighbor wants to kill me. But family members are saying, sir, neighbors are so sweet people. They cannot even kill a mosquito. How will they kill him? But he is convinced that my neighbor wants to kill me. So he is holding this belief beta with extraordinary conviction beta. No matter whatever evidence you try to give him, his belief is not changing. So family members are trying to convince him, but he is not getting convinced. So beta ye kya hai? This is an example of delusion. Also beta, when we talk about delusion, now we always discuss this last point also. Delusion is unexplained by socio-cultural background. But in certain societies, very good. In certain societies, there are some beliefs na. Like some people believe that if a black cat crosses your way, something bad will happen. काली बिल्ली ने रास्ता काट दिया तो कुछ अपशगुन हो जाएगा. They believe it so firmly that they may wait for half an hour, 1 hour. If somebody else don't cross by, they will hardly move. So this also seems to be a false, fixed, firm belief held with extraordinary conviction. बेटा उसको but हम क्या कहते हैं? We don't call it delusion बेटा. What we call it? We call it superstition. So again, they may just ask you, beta, the last point helps us differentiate delusion from superstition. Superstition can be explained by the social cultural background. Other people in that society may also believe that. But delusion, remember, it is unexplained by the social cultural background. With this, beta, let's now discuss the question which they ask again and again, the types of delusion. Now, what is delusion of persecution? But again, what do you mean by persecution? Persecution means to harm or to kill. So here the patient believe, as you can appreciate that question na beta, patient ko lagta hai neighbor wants to kill me. This is an example of delusion of persecution. But please remember, persecution does not always mean kill. Harm in any way. This question was asked in the FMG exam. A 16-year-old female thinks that the school principal along with the teachers want to fail her in the exam. So what is this beta? Again, this is delusion of persecution. If I ask you beta, in psychiatric disorder, which is the most common delusion? Beta, which is the most common delusion in psychiatric disorder? Beta, please remember, it is delusion of persecution. Let's discuss the next delusion. So what I've done, I've clubbed these delusions together so that it becomes easy for us to remember. Beta, what is delusion of reference? See, the name is telling you. Patient thinks that jo bhi aaspaas ho raha hai, everything which is happening around him is in reference to me. So patient may think that people are talking about me. So we are walking with the patient, beta, those strangers are very far away from us. Patient says, sir, they are talking about me. You say, how do you know? We cannot hear what they are saying, but वो convinced है. He goes to the strangers, उनका collar पकड़ता है and asks, why are you talking about me? The strangers say, we are not talking about you. So this is delusion of reference. Or the patient may think that somebody is spying on me. Sir, there are hidden cameras, somebody is spying on me. So again, this is an example of delusion of reference. But also appreciate, sometimes, such newer questions may be asked. A patient says that on the TV, in the television, in the news anchor is giving him some secret message. Can you tell me what is this example of? Beta, I'll discuss this question again, a similar question again. Can you tell me, beta, what is this? Haan, Here, can you appreciate, he is saying that the news anchor on the television is giving me some secret message. So there is something happening in reference to him now. So again, this is an example of delusion of reference. I hope this is clear to everyone. Again, it's a psychotic symptom delusion, so it can be seen in various conditions like schizophrenia, acute psychosis, which we'll discuss. Let's discuss now beta next two delusions together. So the next delusion beta which we are going to discuss is delusion of grandiosity. Beta grandiosity ka matlab hai big. So here the patient is making false big claims. So patient may say I am the king of the world. Patient may claim that I have supernatural power. Just like Thanos, he thinks I can snap my finger and do anything. He's not doing anything, but he thinks he can do anything. Or he may say that Prime Minister asked me what should I do. I am a Donald Trump, the president of USA again. Although his neighbor does not know him, but he is claiming such big claims. So this is delusion of grandiosity. So patient may claim, you know, as if I am God. So this is delusion of grandiosity. But again, it's a delusion, but it can be seen, apuni bhagwan hai. So delusion is a psychotic symptom. It can be seen in disorders like schizophrenia. Can you tell me a mood disorder beta in which sometimes you may find delusion of grandiosity? Any mood disorder beta where you may find this? Please remember, in mania, we'll discuss even in mania other delusions can also occur. So sometimes in mania you may see psychotic symptoms such as delusion of grandiosity. Now in delusion of grandiosity beta patient is making big claims now. So let's discuss a opposite delusion, that is delusion of nihilism, or also known as delusion of negation. Beta here, as the name suggests, patient is negating everything. So patient beta is denying the existence of his body. Patient says, sir, I am dead from within. I don't have a brain, I don't have any intestine. So patient says I am dead. Or he may claim that my family members, my loved ones are dead. His brother is standing in front of him saying, Arey, what are you saying? I am standing in front of you. But he says, no sir, everybody is just a plank of card. Or patient may claim that this world is a dead world. ये मरे हुए लोगों की दुनिया है. So this is delusion of negation or nihilism. But also, can you appreciate, here patient has become as if extremely negative now. So can you tell me a mood disorder in which you may find this delusion? Very good. Beta, ये कहाँ मिल सकता है? Also can be seen in disorders like depression. Very good. In fact, beta, there is a term in literature known as Cotard syndrome. What is Cotard syndrome? It states somebody who has developed depression, and in depression the patient has developed such nihilistic delusion. So this is Cotard syndrome. But a very interesting question was asked in the exam. I'll repeat that question again so that you are very careful when you are handling such questions. See, in the question they say that patient is having depression and patient says I am dead, I don't have a head. So what is the point of eating anything? You have to tell me which delusion is seen here. Beta options may, let me give you options. Beta option A is delusion of nihilism. Option B is Cotard syndrome. Let me see if you can answer this question. I hope you remember this question. It's a question which has been asked in INI-CET, but one has to be very careful. Beta question है कि depression है patient को, patient says I am dead, I don't have a head, what is the point of eating anything? And they are asking you which delusion is seen. Delusion of nihilism or is it Cotard syndrome? Very good beta. A or B? No, C option is not there. You have to choose from A and B only. Okay, so I have eased out for you, only two options I have given. Try to answer in the class, doesn't matter if beta, even if you are wrong now, it will be very useful. Very good beta. Please remember, see, always read the last line very carefully. In the question they are asked you which delusion is seen. So the answer is delusion of nihilism. Beta sometimes it's just a play of word, hai na? We always say this, that your exam is not just about knowledge, but it is sometimes also about English language. So please read the question carefully before answering. Let's now discuss two delusions which have different names. So one delusion beta we'll discuss, that is also known as de Clermont syndrome or erotomania or delusion of love. What is love? Of course, I'm not asking the philosophical definition, very difficult to define love. But when you say love, you say, I love that person. But in delusion of love, but a patient claims someone else, usually of a higher stature, is in love with the patient. For example, a 24-year-old female claims that the superstar Salman Khan is in love with her. She says, sir, वो जो movie आई थी किसी का भाई किसी की जान, उसमें वो जो जान है वो मैं थी. The Big Boss show which he hosts, the eyes of the Big Boss is telling me that he's looking for me. Although the actor might have never met this person, but patient claims someone else, usually of a higher stature, is in love with the person. So this is what? This is delusion of love. But again, we are talking about something related with dil or love, na? So you can remember it with the mnemonic del. Declarant syndrome, erotomania and delusion of love. I hope this is clear to everyone. So very good. Now all of you are SRK loves patients. So yes, so all of you are now giving these examples. Very good. Let's discuss one more delusion beta which has different names. So what is this delusion? Othello syndrome, beta, also known as delusion of infidelity. What is the meaning of infidelity in English? Infidel, my partner is infidel, that my partner is cheating, is having an affair. Also known as morbid jealousy. So here the patient claims that my partner, my husband or my wife is cheating, is having an affair. Everybody is trying to convince a 40-year-old male that the wife is not cheating, but he is not getting convinced. तो बेटा क्या phenomena है ये? This is delusion of infidelity. बेटा now they may just ask you questions in two layers. So they've given you this phenomena where you have identified this delusion of infidelity. The question which they may ask, again beta this may come as a new question, they may just ask you which substance he is consuming. Can you tell me which substance may also be associated with this delusion? Very good, yes beta. It may be, it may be associated with alcohol. Very, very important. So in the end they may just ask you which substance he is consuming. So in alcohol sometimes we see that patient is consuming alcohol for a long time may develop this delusion that my partner is having an affair. I hope this is clear to everyone. So please be very careful, identify the phenomena and then see what they are asking in the question. Let's complete this topic of delusion beta with again a very important syndrome, that is delusional misidentification syndrome. Beta again, can you appreciate from the name? Here there is problem in identity of the other person. So person is identifying people as someone else, misidentify. First important syndrome is beta Capgras syndrome, and I have given you one very simple trick beta. I always say na, see the name and you will remember. So what is the trick? Just see the name beta, see in the name only the trick is there. So just see the name Capgras syndrome. Can you just appreciate the alternate letters? So Capgras syndrome, the name is telling you that patient को लगता है a close person has been replaced by a stranger. So person thinks somebody closely related to me has been replaced by an exact double. So let's bring one patient in the class beta. Let's say we have a patient Mr. Cap for Capgras. He is admitted with us. His actual wife walks in the hospital room, in his room, and she sees his wife and says, you are looking like my wife. Of course beta, she is wife only, so she'll look like wife only, but he says that you are looking like my wife, you are not my wife, you are a hospital staff in disguise. So patient को क्या लग रहा है? That a close person, in this case his wife, has been replaced by a exact double. Beta, can you appreciate the physical appearance is same or different? Can you tell me beta? Physical appearance, you would say sir it is same now, because it is the wife only, so physically she will look like wife. So this trick beta which I have always given you, please see this trick. Tell me, in this scenario in Capgras syndrome, C for Capgras, he is fighting with C for close person. So please remember this in the question or in this situation. Can you appreciate that he is fighting with the wife now, that you are not my wife, you are somebody else in disguise. So this is Capgras syndrome. Now can you tell me a question which has been asked in your FMG exam? Can you tell me an important dementia, cause of dementia in which sometimes patient may present with Capgras syndrome? Can anybody tell me? Do you remember that dementia we'll discuss again starting with L? Again, can you tell me? We'll discuss that dementia, very important beta. Please remember Lewy body disease. So in Lewy body disease we'll discuss Capgras syndrome is one of the supportive features. We'll discuss about it. So this is Capgras syndrome. Let's discuss just the opposite of this, which is Fregoli syndrome. But now what is happening in Fregoli syndrome? Here patient thinks that a familiar person, patient thinks somebody I know, a familiar person is imposing as stranger. तो patient को लगता है कि अब familiar person, somebody I know, मेरे सामने stranger बन के आ रहा है. And he may also think that that person can take multiple appearances. So let us bring one more patient in the class. But let us say we have a patient Mr. Freg for Fregoli. He is walking on the street. He see one stranger, let's call him S1. But a stranger ka matlab he has never met this person before in his life. He sees a stranger and he says, you are looking like a stranger, but you're not a stranger. You are my wife in disguise. What are you doing here? Go back home, go back home. So patient को क्या लग रहा है इस सिनारियो में बेटा, a familiar person, his wife, is imposing in front of him as a stranger. He goes forward, beta, he sees another stranger, let's call him S2. Again he sees this stranger and says, you're looking like a stranger, but you're not a stranger. You are my wife in disguise. What are you doing here? Let's go home, let's go home. तो ये क्या है बेटा? This is Fregoli syndrome. You know, as if patient thinks that person can wear different mask, so person can change his appearance, may impose as stranger. Is this clear to everyone? Beta, very important, please remember delusional misidentification syndrome. Such scenarios may be asked in the exam. So we have covered a very important topic. In fact, beta, see, physical appearance, if I ask you, beta, Fregoli mein kya hoga? Same or different? You will say, sir, it is different na, because they are strangers. Again, the clue is, tell me, they are fighting with, the patient is fighting with, in Fregoli, with close person or with strangers? As you can see in this scenario, na, with the strangers. Very good, beta. I hope this is clear to everyone na. So we have covered a very important topic, that is delusion. Okay. They have also asked a question like this. They will give you a clinical scenario in which they will give you multiple delusions in the question. You have to identify all the delusions. So please see all the options carefully and then answer. Okay. Let's now discuss the next important domain of thought, beta, that is form. So let's now talk about the abnormalities of form. Beta, form means organization. See, our thoughts are organized. They are logically connected. Pick up any of your thought, but आप देखोगे कोई भी आपका जो thought है ना, it is logically connected. It has a start, it has a middle part, it has a end, और सब कुछ logically connected होगा. So that is the meaning of form. Form means structure or organization. बेटा अगर form में problem है, if there is problem in the form, we call it as formal thought disorder. Can you appreciate from the name itself? Okay. Is it clear to everyone, beta? So please remember, tell me, in formal thought disorder, tell me the thoughts are organized or disorganized, beta. Let's focus on the class. Doesn't matter, beta. Let's focus on the class and the concept. Okay. There is disorganization of thought. And can you tell me, formal thought disorders, we will read in which important abnormality? Beta, when we'll talk about schizophrenia, na, in schizophrenia, we will discuss there are 5 symptoms according to DSM-5, and the third symptom is disorganization. So if there is problem or disorganization, beta, in the thought, can I say that speech is also disorganized, right? So let's discuss some abnormalities. But before coming to abnormalities, beta, let me give you example of a normal thought. So let us take this as a normal thought, beta, A followed by B, C, D. Can I say everything is logically connected now? So this is a normal thought. Let's pick up one more thought. Suppose you want to have food outside, you want to have coffee outside. So what thought will come in your mind? You will say, sir, I will book a cab, I'll reach cafe, I'll order food and coffee, I'll eat, I'll pay and I'll come back. Can you appreciate, but it's a logically connected thought na, सब कुछ logically connected है, start है, middle point है, end है. You're able to understand. So ये क्या है? It's a normal form. Let's now discuss some abnormalities. But the first important abnormality is loosening of association. See the name. The name will give you hint. But the name is telling you that the association between the thoughts now that has loosened up. So there is breakdown in the logical connection between the thoughts. So जो thoughts पहले logically connected थे बेटा, वो जो logical connection है that has now broken. So you will say, sir, words may make sense, sir, words समझ में आ रहे हैं, but what he is trying to say, sentences I am not able to understand. So words will make sense, sentences will not make sense. Let's compare it with the normal thought. So here, if a person is having beta loosening of association, his thoughts will appear like this: B followed by D followed by A, E, C. So can I say everything is now hodgepodge? There is loosening of association. Let's ask this person if he wants to have food outside, what he will do. So person may speak like this: sir, I will eat, I will book a cab, I will come back, I will pay, black umbrella. Now can you appreciate? You will say, sir, words I am able to understand, but I am not able to understand what he is trying to say. So this is loosening of association. But let's discuss that question again. So if you remember, we have discussed one question, this question. But sometimes in your exams, the examiner will give you 2 options which may be confusing. So you should also know how to differentiate between these 2 conditions. But can you appreciate, here also you will say, sir, I am not able to understand the words. And they have not mentioned speed in the question. Now we know, in loosening of association also sometimes you may see that you are not able to understand what the patient is saying. But how will you differentiate, beta? One difference is that the speed in flight of ideas is increased. Here the speed is normal, but speed is not given. Still, why you have said it is flight of ideas, beta, and not loosening of association? Can you tell me why? Because see, we have discussed that in flight of ideas you may see some connection. So remember, connections are present here, but there is no such connection in loosening of association. So here you can see by chance connection, and also there is some rhyming. I hope this is clear to everyone. I hope this is clear, beta. Very good. Now let's discuss some more other abnormalities, beta. I hope this is clear now. Let's move on. This is derailment. Beta, what do you mean by derail? So a train, can you appreciate, is moving on track and suddenly it gets derailed. Patri se utar jana, jumping off the track to proceed to a different topic, or also sometimes known as knight's move thinking. Beta, how does a horse move on the chessboard? It goes straight and then suddenly takes a right or left. So patient is on the topic for some time, suddenly he jumps off the track, goes to a new topic. Beta, this is derailment. I hope this is clear to everyone, beta. So for example, let's discuss it with the normal thought. So in derailment or knight's move thinking, suppose the person is on the track, beta, for some time, A followed by B, but rather than going on the track, suddenly he changes the track, L, M, N. He moves to a new topic. For example, you are discussing, or let's say ask this patient, what will you do if you want a food outside? So he will say, sir, I will book a cab. I will book a cab. I will reach cafe. So can you appreciate he's on the track for some time? But rather than going on the track, the person just changes the track and says, sir, IPL matches are going on. I hope my favorite team wins this time and I'm cheering, rooting for my favorite team, and goes on. So can you appreciate, beta, baat karte karte achanak se the topic has changed and there is no connection between these two thoughts. So this is derailment. But I hope this is clear to everyone. Na? Very good. So all of you are giving me different examples. Very good. So this is derailment. Beta, please remember this point. Let's also discuss the next important abnormality, beta, which is tangentiality. Again, just see the name. It is made from the word tangent. But in school days, teacher would say, draw a tangent to a circle. So it's a line which touches the circle at one point and it goes away. Beta, kya tangent ever returns to the circle? Kya वापस आता है? No, it doesn't come back. So here, the patient just touches the topic and goes away. So tell me, beta, goal is reached or not reached? Goal is reached or not reached? It is very good. It is not reached. So patient just touches the topic and goes away. Na? Like Nawazuddin Siddiqui ke dialogue, tak karke chala gaya. This is tangentiality. But sometimes they compare tangentiality with circumstantiality. Can you appreciate, in circumstantiality, person gives unnecessary information but reaches the goal. So let's ask this patient again the same question. Who is your favorite actress? So patient, what he will do, beta, he will just touch the topic. The person may say that, sir, I like Indian movies, especially the dances. You know, in fact, I was watching Kabir Singh and even I am planning, sir, to take up orthopedics and it's a good branch, and so on and so forth. So can you appreciate, he just touched that topic and he has gone. Has he answered back your question? No. So this is tangentiality. But also please remember, a very interesting question has been asked in your exams. Can you differentiate derailment from tangentiality, beta? Please try to appreciate this point also. Beta, kya dono ko differentiate kar sakte ho? Very good. Okay, so some RCB fans are also there. Very good. Now tell me, in derailment, can you appreciate for some time he's on the topic and then he changes the topic and there is no connection? While in tangentiality, from the beginning, he just off track. He touches the topic and he goes away. Let's discuss what is, beta, neologism. See, again, just see the name. Neo means new, beta. Logos means word. So patient, you know, suddenly starts using a word whose derivation you are not able to understand. But wo word does not exist in the language known to the patient, or it is, you know, he is using it with a very different meaning. So this is neologism. For example, beta, hum patient se baat kar rahe hain and we are discussing his daily routine. Patient says, sir, I woke up in the morning at 6 o'clock. I went for a run. I came back. I took a shower and, you know, doc, I bought a new Pratt knit kit with go. And you are confused. What is this? You googled this word, no such word is there. You opened Oxford dictionary, no such word exists. And he says, sir, it is very nice. It is white in color. But abhi bhi aapko samajh mein nahi aa raha, what is this? Then he points to his pen. Sir, I've got a new Pratt knit kit with go. But are you able to understand how he has given this pen this word? No. So this is neologism. But a patient ke mind mein a new word has come, you know, whose derivation you are not able to understand. So this is neologism. Can you tell me, beta? Can you tell me? No, beta, I am watching app chats also. Don't worry. Beta, I am watching all your chats. Don't worry. Some words like non, tap on, tapi, jaunt. So all these are neologism. Okay. I hope this is clear. I am watching both the chats. Don't worry. Okay. So again, if I ask you, beta, neologism is seen in which? Neologism, beta, agar main aapse puchun, is seen in which condition? So you will say, sir, it is a formal thought disorder. It can be seen in condition like schizophrenia. But I hope this is clear to everyone, na? But a difference of what you want me to discuss. Beta, dekho, derailment mein, I am saying for some time he is on the track, then he changes the track. So I'll show you one question which was asked in FMG exam. Very interesting question which will clear all the doubts. Derailment, he should be on the track for some time, then he has changed the track. While in tangentiality, beta, from the beginning he is off track. He just touches that topic and he goes away and does not answer back the question. So this is tangentiality. But I hope this is clear. We'll discuss one question. Let's discuss few more abnormalities beta of formal thought disorder. One is verbigeration and a more severe form is word salad. Like what happens in a salad, beta, everything is jumbled up, mixed up now. So there is senseless repetition of words, phrases or even sounds. For example, a patient may just speak like this: I am umbrella black, I am umbrella black, I am umbrella black. So there is just senseless repetition of words, phrases, sometimes just sounds he is repeating. It is so severe that you are not able to even understand the words. So this is verbigeration. But can you differentiate? Can you differentiate perseveration from now verbigeration? Tell me in the chat box, beta, yes or no. Tell me. In perseveration, we said that initially it was relevant, but now it is getting repeated beyond the point of relevance. That will be perseveration. In verbigeration, beta, there is just senseless repetition of words, phrases or sound. Very good. It is making sense in perseveration initially. Very good. Let's discuss, beta, one more abnormality. Talking past the point, also sometimes known as verbigeration. As the name suggests, person is talking past around that point. So suppose you ask patient a question. Suppose I ask patient, what is the color of grass? Beta, what is the color of grass? A very simple question I have asked. And the patient says it is red. Now can you appreciate from the reply, it appears that he understands the question but is talking about associated topic. So red color say you got it that he understood the question. So this is talking past the point. It does not mean, beta, that color of grass around his house is red. Here it is talking past the point. So what abnormality seen in the mind? It is talking past the point. Suppose I ask him color of grass and he said Kanyakumari. Now from the answer it appears he didn't even understood the question. So that is not talking past the point. So this is talking past the point. And one important point, beta, which has been asked previously in the exams, Ganser syndrome. Just like we discussed, beta, what was Cotard syndrome? Remember we discussed when a patient having depression develops delusion of nihilism, that we termed as Cotard syndrome. Beta, what is Ganser syndrome? Beta, it was seen initially that talking past the point, beta, initially when it was identified, very good, it was seen in prisoners. It was identified in prisoners. So then they gave this term Ganser syndrome. But of course now we know it is not just limited to prisoners, it can be seen in other population as well. So this is Ganser syndrome. But how to remember? You can remember it like this, na? Ganser syndrome is seen in gangsters. So this is Ganser syndrome. But I hope this is clear to everyone. We have discussed another very important topic of thought, that is form. These are all very important topic. But in tangentiality, see, whatever he is saying, beta, is making sense. But he touches the topic and he goes away. While is it clear? While in verbatim, beta, the reply, just a few words may be there in the reply and that reply is telling you that he understood the question, but he is talking around that point. Okay, while in tangentiality, he will go away. He will go away. So that will tell you in the question that he has just touched the topic and he goes away. So that is tangentiality. Point number 1, beta, I will repeat again. Which point? Loosening of association में बेटा there is breakdown in the logical connection. जो thoughts logically connected थे बेटा initially, वो logical connection चला गया. For example, when I am asking this person, what will you do if you want to have food outside? He is saying, sir, I will eat, I will book a cab, you know, I will come back, I will place order black umbrella. So यहाँ पे आपको पता चल रहा है कि words are making sense, but you are not able to understand the meaning of the sentences. That means in the mind, what problem is there? The association between the thoughts, that has loosened up. Is it clear to everyone? Beta, it is a wrong answer, but can you appreciate, you ask color of grass and he is replying red, beta. Had he replied, let us say, had he replied Kanyakumari, then you would have said that yes sir, it is not making any sense. But here, can you appreciate, this red is telling you that maybe he has understood the question, and in the mind the problem is such that he is talking past that point, talking around that point. Is it clear now? For example, you ask a person what comes after Tuesday, he says Sunday. But again, from this answer Sunday, you are able to appreciate he understood that you are asking a day. Okay, so this is talking past the point. Very good, beta. Very good. Beta, see this question. This is one of the question, beta, which was asked in your exam. Now just seeing this question will help you understand the meaning. So see, a psychiatrist asks a patient, how is your mood? The patient replies, it is up and down. Now you have to tell me what is the right answer. Let me ease out for you. It is not neologism now. There is no rhyming, so there is no clang association. Now you have to tell me, beta, answer is C or D. Tell me. Tell me what is the right answer, beta. Is it C or D? Let me see if you can answer this question. Very good, beta. Can you appreciate, beta, to call it derailment, it should be evident that he is on the track for some time and then he has changed the topic. No such thing is evident in this question. I appreciate it's an incomplete question, but this has been asked and it's a good way of differentiating. But can you appreciate, you ask a patient how is your mood, he has just touched that topic. But up and down does not mean happy and sad. It appears as if he has just touched that topic. So yes, out of the option you will say, sir, it is option D. This is tangentiality. So that is why I am saying, beta, sometime you will see such conceptual questions also being asked. So please try to first rule out the option and then try to see out of the option which is the best answer. I hope this is clear to everyone, beta. It's making sense now. Is it clear, beta? Beta, initially, na wo toy mein initially it was appearing that yes, it was making sense, but now he's repeating again and again. Okay, right? Beta, I'll repeat again, beta. Dekho, you have asked a person how is your mood and see what is his reply. He says it is up and down. It appears, see, it may appear to be an incomplete question, but when we see all the options, beta, we know there is no new word. So there is no neologism. There is no rhyming also. There is no clang association. See, for derailment, what should be there? In the question, they should tell that he is on the topic. Let us say he has said it is up and down, then he's gone to a new topic. That is not evident now. Jumping off the track is not evident. So we know it is not derailment also, beta. So can I say here, out of the option it appears na? So the purpose of asking such question is to make you understand the difference. So tangentiality may we know that he has just touched the topic. He says it up and down. From up and down, you will not say it is happy and sad. You will further inquire what do you mean by up and down. So as if he has just touched that topic and maybe he will go away. So this is tangentiality. But a Ganser syndrome, I'll again repeat, Ganser syndrome was initially when talking past the point was identified, it was seen, it was found in prisoners. So that was termed as Ganser syndrome. So remember, Ganser syndrome is when talking past the point was seen in prisoners. So Ganser syndrome seen in gangsters, you can remember it like this. But of course now we know it can be seen in other populations as well. Now it is clear. But yes, part till lunch it will be both on YouTube and the app as I am told, and after that it will be in the app. Right. Let's now complete this topic, beta. Let's discuss the fourth domain of thought, that is possession. But what do you mean by possession? Suppose if I ask you, the thoughts in your mind are your thoughts या आपके पड़ोसी के thoughts हैं? You'll say, of course, sir, these are my thoughts. I possess my thoughts. But sometimes person may say, no, sir, these are not my thoughts. So possession का मतलब है either the person is not able to control his thoughts or he has lost that possession of thinking. Two important abnormalities, beta. One is obsession. Beta, please remember we have discussed this. Obsession is also rhyming with possession. No? So remember, obsession is an abnormality of possession. In some psychiatric book, it is placed also under content. But please remember, for your exams, obsession is an abnormality. Better answer would be possession than content. And where do we see, beta, obsessions? Beta, obsessions kahan milte hain? They can be seen in OCD. So when I will discuss OCD, I will give you also a trick to remember the features of obsession. Remember, obsessions are repetitive thoughts. So patient के mind में बेटा there are thoughts coming again and again, 2 hours, 4 hours every day. Patient says, sir, मैं अपने thoughts को control नहीं कर पा रहा, I'm not able to control. और patient के mind में some images are coming again and again. और बेटा some impulses. बेटा what are impulses? What are impulses, beta? Impulses are urges. Impulses are urges. So patient के mind में some urges are coming again and again. And in fact, beta, please remember this is a PYQ. This question was asked in your FMGE exam, that a person is having irresistible urges to do an act. What is this known as? The simple answer was, it was impulse. Okay, sometimes they may just ask questions from the basic definitions also. Beta, please be very careful. And the last phenomena is thought alienation, beta. See, the name will tell you, na, beta, alien. My thoughts are not mine, alien. Thought alienation, also known as passivity of thought. Beta, again I have given you this trick now. Whenever in psychiatry you read this term, beta, passivity. Passivity का मतलब क्या है, beta? Beta, tell me, what is the meaning of passivity, beta? Passivity means, so whenever in psychiatry you read this term passivity, it means that it is under someone else's control. So just remember this, under someone else's control. Okay. So passivity of thought means that my thoughts are under someone else's control. So 3 phenomena beta come under this. One is thought insertion. As the name suggests, patient experiences, beta if this is the patient experiences, sir, somebody is inserting thoughts in my mind. So there is one thought in my mind that I should go and watch a new movie today. So this thought is not mine. Somebody has put this thought in my mind. Next is beta thought withdrawal. Beta what do you mean by withdrawal? Taken away. So patient says, sir, somebody has withdrawn thoughts from my mind. I don't remember what that thought was. And another is beta thought broadcast. Patient says my thoughts are getting broadcasted outside. In the question they are saying patient thinks everybody in the room is able to know my thoughts, as if my thoughts are getting broadcasted. Beta ye kya hai? Thought broadcast. Let me discuss one more clinical scenario beta. Please see this. A patient claims that the news anchor on the television is telling my thoughts to everyone outside. Beta, can you now tell me what is this phenomena? Ye kaun sa phenomena hai? This is thought broadcast. Can you differentiate it from that earlier question where a patient was thinking news anchor is giving me some secret message? That was delusion of reference. Yahan pe patient says my thoughts are getting broadcasted outside. This is thought broadcast. Can you tell me beta again, last question is thought alienation phenomena. Can you tell me beta it may be seen in which condition? Can you tell me beta in which condition thought alienation phenomena can be seen? It can be seen in conditions such as schizophrenia. Okay. So I hope this is clear to everyone. Beta, we have covered a very important topic, that is abnormalities of thought. Very good. Beta thought withdrawal mein patient experiences that somebody is withdrawing away my thoughts. Sir, there was a thought in my mind 5 minutes back, but somebody has taken away that thought. किसी ने वो thought withdraw कर लिया है. अब मुझे नहीं पता वो thought क्या था. So this is thought withdrawal. Is it clear beta? Insertion में somebody is inserting thoughts in my mind. Withdrawal में somebody is taking away my thought. And broadcast में beta क्या है? Patient says that my thoughts are getting broadcasted outside. Right? Let's see some questions beta. Please appreciate this is again a PYQ. It's a FMG ka PYQ. Now I'm sure you can answer this question. See, don't be worried in the exam if the question may appear lengthier, but sometimes it's very easy. A doctor asks a patient about her age. The patient responds, you know doctor, I am from a village. We were married at a very young age, at 12, with my husband who is just 5 years older than me. Then I had 2 kids when I was around 18 or something. Now I am 38, but look like their older sister doctor. What thought phenomena can be seen? Can you appreciate beta? Very good beta. Why you are saying it is circumstantiality? Very good. The age was asked. Can you appreciate patient has given unnecessary information, but ultimately has the patient answered back the question? Yes, you will see the patient has answered. So it is not tangentiality beta. Also, can you appreciate even in flight of ideas beta, because speed is not mentioned in the question na. Patient is saying so many things, but still can you appreciate in flight of ideas, you will see that person may be saying things which may not make much sense and you may see some connection. So again, it is not flight of ideas, it is not derailment, it is circumstantiality. I hope this is clear to everyone. हाँ बेटा ये भी देखो कि unnecessary information है ना, he is talking about those topics, no unnecessary, just some trivial information, some unnecessary details and answer back the question. So this is circumstantiality. Very good. Let's see one more question beta. Please see this question. Just read this question, don't read the option and try to answer the question beta. Then read the question, options. Beta sometimes again in psychiatry you will see they may give you new terms. They may give you newer questions, but if you see the question, see the options, I'm sure you can answer this question. A patient believes his feelings and thoughts are controlled or influenced by an external agency. So you may be thinking about some thought alienation phenomena, but see the options. They're talking about some delusion. Very good. But it is not delusion of nihilism. It is not delusion of reference. Can you appreciate it is also not Othello syndrome? From the options, yes, it is delusion of influence. Again, a subtype of delusion of persecution where the person may have this belief that his feeling thoughts are controlled or influenced by an external agency. I hope this is clear to everyone now. So please, whenever such newer terms also may come, please be very careful. In fact, this term again was repeated even in INI-CET exam. Okay. So this was about the disorders of thought. So in a nutshell beta I have given you, we have talked about abnormalities of flow, content, form and possession. Okay, so we have discussed a very important topic, that is beta delusion of reference mein kya ho raha hai, patient thinks that everything which is happening is in reference to me. So patient is saying that people around me are talking about me, or the patient is saying that the news anchor is giving me some secret message, or somebody is spying on me. So he thinks things around him are happening in reference to him. So this is delusion of reference. Okay. Let's answer this question beta. It's a INI-CET ka question, but I'm sure we can answer this also. Very simple now. What is delusion of grandeur beta? It's a belief that one is rich. Beta, it's a, again इस question में भी देख लो beta. See in this question also that same delusion was given beta. Delusion of persecution, patient thinks someone is planning to harm him. Okay. Nihilistic delusion, believe that world has ended, nothing is left. Again, can you appreciate here also now they have repeated this in the next INI-CET exam. Delusion of influence, but influence here there is a delusional belief that his thoughts actions are influenced by others. So the answer is A2, B1, C3 and D4. So the answer is option A, right? So in the MSc beta we have covered a very important topic, that is thought. Let's discuss the next important abnormality under, or let's discuss another important heading in MSc, which is disorders of perception. Beta, what is the meaning of perception? First, please understand very basic meaning. What is perception? How we perceive the external environment. For example, beta, you can hear me, you can see me, you can smell things, you can taste things, and also you can touch things, you can feel things. So this is perception. This is how we perceive the external environment. Now suppose a patient comes and says, sir, on the screen along with you I can see another person sitting. He is wearing a white cap, he has a mustache and is wearing white shirt. Beta, can you see anybody else other than me on the screen? I hope no, है ना? But उसको दिखाई दे रहा है ना beta, he is able to see. That means it's a problem of perception. So let's discuss some important abnormalities beta of perception. First is illusion beta. Let's discuss beta what is illusion. Illusion, देखो, it's an abnormality of perception, so it's a false perception beta, but of a real object. There is a real object, but the person is perceiving it something else. So please see this. I'm sure most of us have experienced this now. Suppose somebody is sleeping in the night, and in the night he wakes up and he says, I can see a snake, I can see a snake under my bed. Beta, वो डर जाता है सांप को देख के. He shouts, he screams. Family comes running in, they switch on the light. Then the person sees, oh, actually it was a rope. So can I say this snake is a false perception of this rope now? So this is illusion. So illusion is a phenomenon which I'm sure all of us have experienced. Okay. Let's now discuss, very good beta, let's now discuss a very important topic, that is hallucination. So let's discuss beta what is hallucination. Beta, just like when we discussed delusion, first point what we wrote was that delusion is which symptom? Remember, even hallucination, remember it is also a psychotic symptom. Hallucination also is a psychotic symptom. So let's understand beta what is hallucination. Hallucination, see, it's a problem of perception, na? It's a false perception beta without any real object. Okay, like that person who can see along with me another person on the screen, na? आपको तो नहीं दिखाई दे रहा. So it's a false perception without any real object. And please remember beta, it is very clear. In fact, write down as vivid as real. Just like you can see me, na, he can see that person also very clearly. Just like beta any real object, it is not under my control, na, like this pen I am holding, beta मेरे control में नहीं है ना. I cannot just wish and make this pen disappear. So any real object is not under my control. Similarly, beta, hallucination also is independent of the person's will. So hallucination is what? It's a false perception without any real object, but it is as clear as any real object. It is independent of the will as any other real object. Also beta, tell me one more point, that hallucination patient कहाँ पे experience करता है? Tell me, where does patient experiences hallucination? In the outer objective space. But a patient says, sir, I can see another person in the room. Sir, I am hearing voices coming from within the room, yeah, from outside this room. So this is hallucination. But can you appreciate, hallucination is having all the characteristic of a real object, but the only thing is beta, it is not real, it is false. Have you seen that movie Lage Raho Munna Bhai? In that movie, Munna Bhai can see and hear Mahatma Gandhi. Beta, we know Mahatma Gandhi is no more with us, but usko Mahatma Gandhi दिखाई भी दे रहे हैं, सुनाई भी दे रहे हैं very clearly and not under his control. And where he is able to experience it? In the outer space. So this is classically how a patient may experience hallucination. But there is one more small topic which we always discuss, which finally was asked in your FMG exam as well. What is pseudo hallucination? But a pseudo hallucination also is very similar to hallucination. It is a false perception without any real object. It is also very clear, it is independent of the person's will. Can you tell me what is the difference, beta? What is the difference? Can you tell me where the person is experiencing pseudo hallucination, beta? He is experiencing in the inner, remember, in the inner subjective space. Very important point, and this question came in your exams. Okay, very good, in the inner subjective space. So what is inner subjective space? Let me say, you know, all of us have been to some hilly area. If I ask you to create the image of the last hilly area you have been to, you will be able to create that image in your mind. Na? Now I say that you have spent a lot of time, come back in the class, you will come back to the class. Beta, kahan pe image create hui thi? In the mind. A person says, I can see a person very clearly, not under my control, in the room. It is outside in the outer space, na? So it is hallucination. Sir, in my mind I can see a person very clearly, not under my control. Ye kya ho gaya? Pseudo hallucination. I hope this is clear to everyone, beta. I hope this is clear, na? Please remember this point. Okay. Now let's discuss some important types of hallucination, beta. Just like we discussed types of delusion, let's discuss now types of hallucination. So we have 5 sensory modalities, beta. We have 5 types of hallucination. First is auditory. Beta, what do you mean by auditory? Auditory ka matlab hai person is able to hear things not heard by others. Okay. Again, it could be anything. He is hearing bell ringing or dog barking or some human voice. Most common hallucination, beta, अगर पूछें आपसे psychiatric disorder में कौन सा है, please remember most common hallucination in psychiatric disorder is auditory. Very good. Beta, what is visual hallucination? Visual hallucination means person can see things not seen by others. It could be any object, some animal, or even a human figure. So this is visual hallucination. Beta, one important point, tell me, see, hallucination is a psychotic symptom. It can be seen in psychotic disorders like schizophrenia, other condition. But अगर question में visual hallucination दिया हुआ है, can you tell me a important, you know, an important diagnosis which should come to your mind? Can you tell me, beta, this is a very important question which I am asking, कि अगर visual hallucination, very good, beta, in organic mental disorders, beta, in organic mental disorders, you know, in fact we will discuss in organic mental disorder most common hallucination kaun sa hai, beta? It is visual hallucination. So please remember this point. Of course it can be seen in other conditions like schizophrenia and even other conditions. Okay, so visual hallucination. Next is olfactory hallucination, beta. Olfactory ka matlab kya hai? Smell. Person is able to smell something which others are not able to appreciate. So this is olfactory. Beta, what is gustatory hallucination? Gustatory ka matlab kya hai, beta? Taste. There is no food on the tongue of the patient, but patient को taste आ रहा है, metallic taste आ रहा है, या फिर you know it's a bitter taste he is experiencing. So this is gustatory hallucination. But a patient has developed olfactory and gustatory hallucination after a head injury. Can you tell me which area may be involved? Very good, बेटा कौन सा area involve हो सकता है? Olfactory gustatory hallucination develop हो गए after an accident. Which area it may be? Very good, in temporal lobe disorders. Very good. In temporal lobe disorders, person may develop sometime these hallucination. And the last, again very important, is beta tactile hallucination. What do you mean by tactile? Beta tactile का मतलब क्या है? Tactile means touch. So patient says I can experience insects crawling under my skin. He can feel the insect. Beta this is also known as formication. Small insects patient can experience crawling under the skin or over the skin, also known as cocaine bugs or magnum bugs. Why cocaine bugs, beta? Because it can be seen in cocaine users. We'll discuss this question again. A patient comes to the OPD or comes in the emergency with tachycardia, tachypnea and scratch marks. Which substance he may be consuming, beta? कौन सा substance है? Again scratch marks may tell you. So scratch marks may also occur because of this hallucination. And why tachycardia, tachypnea we'll discuss when we talk about substance use disorder. But I hope this is clear to everyone. Na? Quickly tell me, so that all our doubts are clear, beta, quickly tell me what is the difference. Beta, sometimes students get this doubt, na? So let's take up this doubt also. What is the difference between delusions and hallucination? Both are psychotic symptoms. Beta, please see where we have read. Delusion we have covered under thought, hallucination we have covered under perception. Both start with false, but remember delusion, beta, kya hai? Delusion is a false belief. Patient says, I know my neighbor wants to kill me. This is what delusion of persecution. While hallucination, beta, what it is? It is a false perception. Patient says, I can hear the voice of my neighbor planning to kill me. This is auditory hallucination. I hope the difference is clear to everyone. Na, beta, in the question, na, they will not tell you that it's delusion or hallucination. You have to identify. So understand the concept so that you are able to differentiate. I hope it is clear to everyone. Na? Very good. Beta, let's take up this question. See, sometimes beta such simple questions will also be asked, so please be very careful. A person thinks, so this is your January ka question only beta. A person thinks someone wants to kill him. He cannot be convinced or explained. What is this likely phenomenon? A very simple, a false belief has come in the mind of the patient. Very good. So this is, we know it is delusion, and kaun sa delusion hai? You can also say it is delusion of persecution. Okay. I hope this is clear to everyone now. Let's complete the headings of MSc now. Let's now talk about cognitive functions beta. So cognitive functions or higher mental functions we'll discuss, but a cognitive function ka first important point, remember, see, we are talking about organic mental disorders now. We know organic mental disorders now in both DSM-5 and ICD-11, but they have been given a new term which is neurocognitive disorders. Neurocognitive disorder, but a very important point, please remember, see the name. The name itself is telling you that in neurocognitive disorder, what is affected? You can say, sir, cognitive functions are affected. So we are trying to assess the cognitive function. So let's discuss, but nowadays they have started asking questions from this also. So let's see. First cognitive function we'll discuss is beta orientation. Beta, what is orientation? Orientation means awareness about self and surrounding. Like right now all of us are sitting in the class, beta all of us are oriented now. So how do we assess orientation? With respect to time, place, person. If I ask you what is the time right now, what is the day, what is the date, what is the month or year, you will be able to tell me. Which place right now you are sitting, you will be able to tell me. Who are sitting or who are around you, you can tell me. So you are oriented. A person says he is in the hospital but says I am at my home. Patient is oriented or disoriented beta? He is, can I say he is disoriented na? There is disorientation, and please remember beta disorientation can be seen in one important condition. D for disorientation beta we'll discuss, D for delirium. Very good. So you are able to tell me all these things, time, date, very good. And we know delirium is a neurocognitive disorder. Beta next is attention. Dekho, again don't mug up any definition. See, in the classroom teacher would say pay attention. So what does that mean? Focusing on one particular stimulus. So attention ka matlab hai ability to focus. So what is the test? Beta sometimes they may just ask you the test. The test which we use to assess ki kya attention intact hai nahi is digit repetition or digit span test. Beta we give some digits to the patient and ask him to repeat. Beta there are two components, digit forward and digit backward. Beta forward mein kya hoga? The person has to repeat the numbers in forward direction. Suppose I say 2, 7, patient will say 2, 7. Then I will increase the number. While in backward, suppose I say 3, 8, patient has to repeat 8, 3. He has to repeat in the backward direction. Then I will increase the numbers. So remember, a psychiatrist is asking a patient to repeat some numbers after him. What is the psychiatrist assessing beta? He is assessing attention. Beta if both are given in the options, digit forward and digit backward test, and they are asked which is the test for attention, then better answer would be beta digit forward test would be a better answer. Next is beta concentration, which was asked in your FMG exam. See, finally they are asking such question. Again, don't mug up anything beta. Sometimes when you are studying, you say, sir, after studying for half an hour, I lose my concentration. So concentration ka matlab hai beta sustained attention, whether the person is able to sustain his attention for a long duration. And the test which we do is, remember, serial 7 subtraction test or 100 minus 7 test. In this, we ask the person to subtract 7 out of 100. Whatever the answer comes, keep on subtracting 7 till you can. Suppose the patient says 93, 86, 79, 72, 65, and he keeps on subtracting. So normally we say a person is able to do it up to 5 times. So we say that the concentration is intact. This question was asked beta in your exam. A psychiatrist is performing 100 minus 7 test. What is he assessing? Beta, what is he assessing? You will say, sir, he is assessing concentration. Some students said, sir, concentration was not given in the option. So any other answer you can say then beta? Any other answer beta then you can say? Then you can say, sir, it is sustained attention now. So next better answer then would be for assessing even attention. Very good beta. I hope this is clear to everyone now. Please remember this. Let's discuss one more important heading beta, that is memory. See, memory we have divided on the basis of duration beta into 3 categories. One is short term or immediate memory beta. What was the topic we were discussing before memory? You will say, sir, concentration. So you remember what happened few seconds back now. That means your immediate memory is intact. Beta इसे कहते हैं immediate memory. If the person is able to remember things which happened few seconds back, okay, maybe in 10s or 20s or 30 seconds back, those seconds we take. And again, can you appreciate beta? See here, all the test of attention and concentration, beta, we can say in a way they are also checking immediate memory. So we don't have to do any separate test. These tests are also assessing immediate memory. But beta, again, if they ask you tell us one test, then again you can go with digit forward test. Okay, if they ask you one test, then you can go with digit forward test. Please highlight beta, recent memory is very important. Recent memory क्या है beta? Memory of the past few minutes, hours or days. So if something happened few minutes, hours or days back, you remember. That means क्या intact है आपका? Your recent memory is intact. But again the question is asked, what is the test we do to assess recent memory? Please remember, we use the test 24-hour recall method. See, as the name suggests, we ask the person something which has happened in the past 24 hours. If he is able to remember, then we say his recent memory is intact. For example, this question may be asked like this about the last meal. You are asking a patient who, what did you had in your last meal? Suppose if I ask you, what did you had in your breakfast today? But you will be able to tell me na कि क्या खाया. हाँ, तो psychiatrist is asking not to prepare his food menu, but he is asking to check his recent memory. They may ask some newer questions also. That a psychiatrist is asking a person who came to meet you in the morning today. So again, you are asking some event which happened in 24 hours. Na? Again, you are assessing recent memory. Beta, please be very careful. And last is beta, remote. What do you mean by remote? Remote means something which is far. So memory of months or maybe years back. So how do we assess? One of the tests is beta, we can assess by asking personal information. So I am asking a 70-year-old male the name of his school, the name of his school friends. Can you appreciate? I am asking very old information now, very old information. So I am assessing his remote memory. Don't ask this male his date of anniversary. He may not be able to tell you. I am just kidding. But this is how we assess the remote memory. But I hope this is clear to everyone. So we have discussed some important points about memory. Very good, beta. Very good. Let's discuss. Beta. Few more points in the MSc. Let's now discuss beta abstract thinking. See, what do you mean by abstract? Abstract means ability to understand hidden meanings or ability to form concepts. See, all of us are able to understand. Na? Sometimes hidden meanings are there. We are able to understand. So normally we have abstract thinking. Please remember beta, there are two tests. There are two tests which we use to check abstract thinking. Beta, one is proverb testing. What do you mean by proverb? Proverb का मतलब क्या होता है बेटा? मुहावरे. So proverbs carry a hidden meaning. For example, there is a proverb na, pen is mightier than sword, है ना? कलम की ताकत तलवार की ताकत से ज़्यादा होती है. What is the meaning? What is the meaning of this proverb beta? What is the meaning of this proverb? Pen is mightier than sword beta. You will say, sir, it means that knowledge or intelligence is more powerful than muscle. You are able to understand the deeper meaning, your abstract thinking is intact. But a person says, sir, I will tell you the meaning. It means that if I am fighting with someone and I am holding a pen, other person is holding a sword, I will win because I am holding a pen. Does this mean this? It does not mean this. That means he is only able to understand it superficially beta, not go deeper. So can I say, this is a very important point, please remember, loss of abstract thinking beta. Can I say abstract thinking is absent here now? And that is termed as concrete thinking. Very important. Concrete means superficial. He is not able to go deeper into the meaning. But they may just ask you this question, and in the question they may tell you somewhere in the question from the answer it appears that there is loss of abstract thinking. So please read the options carefully. They may give you this term in the question, concrete thinking. Again, it can be seen in conditions like schizophrenia and even in other conditions as well. Okay. So please remember beta, one of the test is proverb testing. One more test we will discuss, that is similarity testing. Beta, here we ask similarity between two objects. Beta, if I ask you beta, what is the similarity between a car and a plane? क्या similarity होती है बेटा कार और plane में? So can you tell me what is the similarity between a car and a plane? You will say, all of us will say, sir, both are. So one similarity you can say is functional similarity, both are mode of transport. Can I say you are able to appreciate a deeper meaning? But some patients are only able to see the structural similarity. Patient says, sir, both have tire, both have seats, both have window. So can I say the person is only able to see superficially, only the structural similarity? So can I say here, when the person is able to tell me the functional similarity, the abstract thinking is intact, while here when he is only able to tell me structural similarity, abstract thinking is impaired. And abstract thinking when it is impaired or lost, beta usko kya kehte hain? What is that termed as? Beta, please remember that is termed as concrete thinking. So please be very careful. They may just ask you such question that a psychiatrist is asking or doing proverb testing or similarity testing. What is he assessing? He is assessing abstract thinking. Is it clear to everyone? Na? Nowadays a lot of us see memes every day. Na? So memes, they carry a hidden meaning. Hai na? If you are able to understand the meaning of memes, that means your abstract thinking is intact. Is it clear to everyone? Now, there is a famous song, na, Akhiyon se goli mare, she has killer eyes. So patient says that means there are guns in the eyes. She shoots from her eyes. No, he is not able to understand the deeper meaning. So can I say abstract thinking is lost? Is it clear to everyone, beta? Very good. Beta, let's discuss the next heading, that is judgment. So we'll discuss, beta, what is judgment. Again, don't mug up anything. In a courtroom, judge hear all the evidence and pass a judgment. Na? So judgment ka matlab hai ability to take the right decision. So all of us take so many decisions every day. Na? So that tells about our judgment. One important judgment, beta, which I will discuss is test judgment. Beta, see the name. Test judgment ke naam se pata chal raha hai that we are giving a test. So I ask or I give a imaginary situation to the person. Beta, my patient ko I give a imaginary situation. Very good. And I ask that person what will you do in that situation? Suppose let me ask you that question which we ask the patient, that fire problem. If I ask you, beta, suppose the neighbor's house catches fire, beta, what will you do? So you will say, sir, I will call the fire brigade, will try to help the neighbor. You know? One of the patients says, sir, you know what I will do? I will pour kerosene in the fire. So can I say from his answer, it appears that the judgment is impaired. Judgment is impaired. Again, it can be impaired in psychotic disorders like schizophrenia. In psychosis, it may be impaired. So this is test judgment. Okay, I hope this is clear to everyone, beta. And last is, beta, insight. What is insight? Insight ke naam se pata chal raha hai, beta, awareness. See, is the person aware of his or her illness? See, normally in medicine or surgery, you may not check insight always. But in psychiatry, we often check insight because in some conditions, the patient is not aware of their illness. Tell me, beta, we'll discuss this classification of neurosis and psychosis. Very good. Tell me, beta, neurosis and psychosis mein where insight is present? Where it is present? Those are in the app as well as those who are in YouTube, beta, I am able to see all your chats. Tell me, neurosis mein insight usually is present. In psychosis, it is impaired. Very good, yes. I hope this is clear to everyone. So we have covered a very important topic, that is MSC. Again, thought, perception, it's a very, very important topic. Now, before coming to the disorders, beta, let's come to the classification. So we know to make a diagnosis in psychiatric disorders, beta, we have some classifications which give us the criteria. Kya duration hai, what is the symptoms? So one is, beta, we have ICD-11 and one is we have DSM-5. Okay, one we have, beta, ICD-11 and one we have DSM-5. Now I will discuss one older classification, beta, which is very useful when we are discussing psychiatric disorders. Beta, up till now, tell me it is clear to everyone. Now, beta, we have covered a very important topic. Let me know if it is clear to everyone. Then we'll start with the disorders. Very good, beta. It's an old classification, but it will be very useful. See, in older times, we divided psychiatric disorders, beta, into organic and functional. Organic disorders are those disorders in which we say that they have a visible cause. The cause is visible. Okay, for example, somebody after head injury develops some psychiatric symptoms. Okay, or after, there is decrease in sodium level going below 130, the person may develop some psychiatric symptoms. So you can see the cause. Okay, while functional, beta, we say that there is no visible cause. Please appreciate this point, beta. I am not saying that there is no cause. I am saying the cause is not visible. Like a patient with depression or with schizophrenia coming to us, we do all the routine tests. They may come out to be normal, or we may not be able to see the cause. But now we know that, all these disorders also have a cause, like there can be genetic factors, neurotransmitter level pe there are causes. So nothing is functional now, we know. So that was the meaning of functional, that there is no visible cause. And then we can further divide beta functional disorders into neurosis and psychosis. Let's now discuss this classification. Okay? But I hope it is clear now. Tell me now, you have to tell me, beta, insight, present where, absent where. Everybody tell me, beta, insight, present where, absent where. So you can say we have just learned insight usually is intact in neurosis, it is impaired in psychosis. See, personality we have discussed, how we deal with day-to-day situations. right? So usually in neurotic disorders, the personality is intact while it may be impaired in psychosis. Family members may say that he's not the same person as he used to be, personality change ho gayi hai. Now reality testing means better touch with reality, whether you are able to differentiate what is real, what is unreal. In neurosis, we know that reality testing is intact. Again, this is important. While in psychosis, you may see the person is talking to someone when no one is around. So I can say that reality testing may be impaired in psychosis. But a judgment, we have just discussed now, that judgment, remember that fire problem we discussed now, that judgment usually is intact in neurosis, it may be impaired in psychosis. Again and again, beta, we have been discussing delusions, hallucination, beta, kaun se symptoms hai? You will say, sir, these are psychotic symptoms. So remember, these are usually absent here, but they are maybe present in psychosis. I hope this is clear to everyone, beta. Also tell me now some examples. Give me some examples of neurotic disorders, beta. Give me some examples of neurotic disorders. For example, we'll discuss anxiety disorders, right? Even OCD, even somatoform and related disorders. Even although depression and mania, we will discuss depression and bipolar disorder, they are mood disorders. But again, you can say yes, depression has many characteristics similar to neurosis. While in psychotic disorders, beta, can you give me some examples for psychotic disorders? Very good. In psychotic disorders, examples like schizophrenia is there, beta. We will discuss many of these psychotic disorders. Even acute psychosis is there, beta. Delusional disorder is there. Even to an extent, you can say, beta, mania or bipolar disorder, mania again having some characteristics. But we have discussed, beta, even depression patients sometimes may develop delusions, even hallucination, and that we call as psychotic disorder, psychotic depression. Okay. So again, it's not a very crystal clear classification, but this classification first will help us understand these disorders, and sometimes you can also answer many questions based on this classification. Beta, for example, if I ask you, let me say I give you a somatoform or related disorder ka question, and I ask you which of the following statement is false. And I may give you some newer options in that question, but one of the option is that in somatoform disorder, I say reality testing is impaired. Now from this classification, you know it's a neurotic disorder and you know reality testing is intact. So that is a false statement. So sometimes just by knowing this classification, beta, you can also solve the question. Okay. Beta, I told you na, after every 2 hours we'll take a break, hai na? So at 12 we'll have a small break, then at 2 we'll have a lunch break. Okay. So we'll discuss, beta, how this classification would be useful for us. Beta, first I will discuss all the organic disorders. We'll discuss psychotic disorders, we'll discuss mood disorders, and then we'll discuss neurotic disorder. So always say, beta, whenever you're revising now, always compartmentalize each subject. It becomes easier for you to understand and answer the questions. I hope this is clear to everyone. Right, so we'll start with a new topic with this very small message, beta. Whatever be the circumstances, I always say, beta, keep smiling, keep moving forward. See, this is not just a 1 day or 2 day journey. It's a journey of, so many weeks or months of your preparation. So always keep a smile. Smiling will not change the circumstances, but it will change the way you are handling things, okay? So there may be ups and downs in our preparation, but keep a smile and take 1 day at a time, keep moving forward. Don't carry the baggage. Beta, many times we say na, sir, kal jitni padhai aaj nahi ho rahi. Don't worry. Jitna bhi kar sakte ho, whatever you can do today, and then when the new day will come, focus on that day. Okay, with that, beta, we'll start with the neurocognitive disorder. Beta, we'll try to keep the class till 7:38 maximum. Okay, let's now start with the first important disorder, which is neurocognitive disorder. But again and again, I'm saying this is a very important topic. In every exam, in FMG exam, you're seeing questions from this topic, and even in January, 2 questions came from this topic. So we know that this is a new term used in both DSM-5 and ICD-11. Earlier it was known as organic mental disorder. The name is telling you, beta, what is impaired here? Cognitive functions are affected and there is a cause. See, in the name only both the things are mentioned. We discussed there is a cause and there is impairment of cognitive function. So both the points have been mentioned in the name itself. So let's discuss, beta, I've given you one table, let's discuss, and then I'll discuss in detail about dementia. So we have 3 important neurocognitive disorders, okay. But organic mental disorder, we are keeping it separate, hai na, in organic mental disorder, okay. So one is delirium. Beta, if I ask you which is the most common organic mental disorder, this has been asked, it's a PYQ in FMG exam. बेटा मोस्ट कॉमन ऑर्गेनिक मेंटल डिसऑर्डर कौन सा है? रिमेंबर इट इज delirium, most common organic mental disorder. This question has been asked previously. Okay, it is the most common. Usually you will see beta delirium में आप देखोगे the onset is sudden, there is acute onset. तो बेटा question में आप देखोगे suddenly the symptoms have started, maybe within few hours, maybe within few days. And also you will see that the symptoms may be fluctuating. So you will see that symptoms are fluctuating, they are having a fluctuating course. Like you will see even in the day, symptoms may be more in the morning, then they may decrease in the afternoon, then again they may increase in the evening. So they may have a fluctuating course. The very important point beta, see in delirium, whenever in the question they are talking about delirium, beta delirium means there is impairment of consciousness. This is a very important point beta, please remember this point. The consciousness is impaired. Consciousness means awareness of self surrounding, but all of us right now we are conscious now. So in delirium, remember there is impairment of consciousness. And I'll give you a trick beta, this is one trick which I always give now. Remember this mnemonic ACDC. If any of these points are mentioned in the question, they are hinting that the consciousness is impaired, and then you're thinking of delirium. Beta, what is A? Somewhere in the question they have mentioned that there is altered sensorium, that the sensorium of the patient is altered. Or they may tell you that there is clouding of consciousness, the consciousness in the clear sky of consciousness, now there are clouds, ab badal aa gaye hain, so consciousness is not clear anymore, it's clouded. What is D? Can you tell me beta? This we have already discussed na. D kya hai beta? Disorientation, patient is disoriented. So somewhere in the question they are telling you he is disoriented to time or place or person. And what is C? They may just tell you in the question that patient is having confusion. So any of these points beta mentioned in the question, they are hinting you towards impairment of consciousness. Think of delirium. Is it clear to everyone? Very, very important. Also remember beta, since it's a neurocognitive disorder, even the cognition is also impaired beta. For example, the patient may have memory impairment, patient may have language impairment. We will discuss all these cognitive function when I'll discuss dementia. Or they may tell you that patient has some perceptual abnormality. Can you tell me which perceptual abnormality may be more commonly seen here? Which perceptual abnormality? Go to the MSc. We have discussed abnormality of perception. Now answer. Which perceptual abnormality beta may be more common in organic disorders we discussed na? Such as visual hallucination. Very good beta, visual hallucination. So patient is admitted in the hospital, in the ICU, he is diagnosed with delirium. He is saying he can see snakes on his bed, or he can see some insects or some person not there in the room. So this is visual hallucination. So please see here everyone, in delirium I am saying both consciousness and cognition both are impaired. Okay. When I am talking about beta dementia, I'll discuss few more. Chalo, let me finish first delirium full point, then we'll come to dementia. See, as we have discussed, it has acute onset, fluctuating course. Also sometimes you will see some risk factors or some predisposing factors may be given in the question. For example, they may tell you that the patient is elderly. Of course, it can occur in young also, but more in the elderly. The risk is more in elderly. Very important, they may tell you in the question, but a person is having some surgical illness. For example, they may tell you that there is a fracture femur. You know, in fracture femur, we know that there is heavy blood loss. Or patient underwent a bypass surgery. There is a bypass surgery which the person had. Okay. Or they may tell you that person has some emergency procedure. There is some emergency surgery like appendectomy. Or the person has RTA. Beta, what is RTA? Road traffic accident. After the accident, patient admitted in the hospital developed some symptoms. Or they may tell you patient has developed these symptoms in the post-operative period. But sometimes we see after the surgery in obs and gynae, in surgery, in orthopedics, 1 day, 2 day, 3 day after the surgery, the person may develop symptoms of delirium. So such risk factor beta may be given in the question. They may also give you some medical illness person had, like an acute infection or some chronic illness he was having. Or they may hint you towards some substance beta. Even some substances are also associated with delirium. Can you tell me an important substance whose withdrawal can cause delirium? Can you tell me a very important substance beta? Very good. Alcohol withdrawal. Alcohol withdrawal, delirium, very good. We'll discuss alcohol is a very important topic for your exam. And उस delirium को क्या बोलते हैं बेटा? Alcohol withdrawal delirium में. So in alcohol withdrawal delirium also we'll discuss क्या important symptom होगा patient में? Impairment of consciousness. That is also known as delirium tremens. So we'll discuss delirium tremens. Okay. So these are some risk factors which they may give you. Let's also discuss the treatment beta. Let's complete this topic because you will see many questions from treatment have also been asked. Now in the treatment, but the first point is, let's first discuss some points about the test. So in the test, of course, beta, you will do all the investigations to identify the cause, beta. Suppose head injury is the cause, then you will do relevant test. Suppose infection is the cause, you will do relevant test. Suppose decrease in sodium, hyponatremia, sodium below 130 is causing delirium, you will check the level. So you will try to investigate the cause. There is one test, beta, that is known as confusion assessment method. Beta, confusion assessment method. This question was asked in one of the NEET PG exam, beta. See, if I ask you, beta, confusion assessment method is used for, options are schizophrenia, mania, depression, delirium. Beta, from the name you can say sir, confusion is seen in delirium. So yes, it is used for delirium. But also remember one newer point, let's discuss that also. Beta, if we, very good beta, if we do EEG, see, usually we may not do EEG in all the patient, but suppose a patient comes to us with delirium, and beta patient koi bhi cause of delirium ka, and we do EEG. What does the EEG shows? Remember, the EEG will show diffuse slowing of the background cortical activity. So it will show diffuse slowing. But there is one important exception, beta, which you should remember. Beta, remember in delirium tremens, beta, delirium, alcohol withdrawal delirium mein kya hoga? Remember this point. I'll correlate this point again when I'll discuss management of delirium tremens. In delirium tremens, alcohol withdrawal delirium, it will show fast activity. Remember this point, okay? It will show fast activity. So we've talked about assessment, beta. Now let's talk about the treatment. See, in the treatment, first point which I have mentioned is, beta, treat the cause. Very good, beta, treat the cause. Why I am saying treat the cause? Because identify the cause, whatever is the cause, treat it. You will see, although delirium, beta, it's a medical emergency. Beta, see, you may find the patient in the ICU, it's an emergency. But remember, very important is, it is reversible. Identify the cause, beta, treat the cause. You will see majority of the cases, they are reversible. But let's discuss some important points, beta. If they ask you, both these questions came in one exam in your FMG exam, beta. Both questions were asked. If I ask you, what is the drug of choice for delirium? Beta, we know in delirium, sometimes patient may develop delusions, hallucinations, even agitation. Beta, you may see patient is very agitated, biting cell, biting others, trying to remove cannula catheter. So because of, some of these symptoms, we may give antipsychotics. Antipsychotics, beta, such as, so we can give antipsychotics such as haloperidol. Haloperidol, beta, is what category? Tell me. So always try to, whenever, beta, जब भी आप drugs पढ़ रहे हो ना question में, please identify which category it belongs to. So all of us will say, sir, haloperidol is what? It's antipsychotic. कौन सा class? First class. First, the class or the typical antipsychotics, okay, or the first generation. But in fact, it is the most common antipsychotic which is used. We can also use other drugs like olanzapine and other drugs as well. So this question was asked in the exam, beta, that a patient has developed delirium, drug of choice. But in that question, both haloperidol and risperidone was given. Risperidone is also second generation antipsychotic, but answer kya, better answer kya? Haloperidol. It is most commonly used. And we can also use benzodiazepines, beta. See, benzodiazepines we have such as lorazepam, diazepam, so many benzodiazepines we have. But see, in EEG we are showing, beta, can you appreciate, in EEG it is showing diffuse slowing of the background cortical activity. And we also know benzodiazepines are also seen as suppressants. So please be very careful, beta. Sometimes benzodiazepine can worsen delirium. But yes, we can use benzodiazepine, low doses of benzodiazepine for managing symptoms like agitation. But you have to tell me, beta, there is one important cause of delirium. वहाँ पे benzodiazepine are the drug of choice. Can you tell me now? Can you tell me now? If I ask you, beta, in which, very good, कौन से cause में, beta, कहाँ पे you will say that benzodiazepine are the drug of choice? कौन से delirium में? One very good in delirium tremens. Very good. So both these questions were asked in one FMG exam. बेटा एक exam में दोनों question थे. They had asked drug of choice for delirium and they had asked drug of choice for delirium tremens. So please read the question carefully and then answer. So we have covered a very important topic, beta, of delirium. I hope this is clear to everyone. Let's now come to dementia. Let's now come to the second important neurocognitive disorder, beta, which is dementia. Delirium is clear to everyone now. Key point, just quickly tell me the key point in the chat box. One important feature of delirium. For your MCQs, tell me one important feature of delirium, beta. A quick recap beta ye one important take home message in delirium I am saying the consciousness is impaired. And remember this mnemonic beta, any point out of these given, this is hinting towards impairment of consciousness. Okay, very good beta. Now in dementia, remember the consciousness in dementia is intact. It is the cognition. So see, it is also neurocognitive disorder na here, but we are saying in delirium consciousness and cognition both were impaired, while in dementia it is only the cognition which is impaired. So it is only the cognition which is impaired. So let us see what all symptoms beta patient may develop when the cognition is impaired. So you must have read these terms beta, even in medicine neurology we read these terms. So let's discuss what are the impairments which can occur. So there may be patient may develop amnesia. Beta, what is amnesia? Can you tell me beta what is amnesia? Amnesia is what? Amnesia is loss of memory. So there is memory impairment beta can occur in the patient. So family members may complain that he is not able to remember things. Then patient may develop beta aphasia. What is aphasia beta? What is aphasia? Very good. Aphasia means, so family members may complain that he is not able to use words properly. There is problem in language. So remember in aphasia there is language impairment. Okay, there may be language impairment. A very interesting finding they may give you in the question. Patient is not able to button unbutton his clothes. He is not able to tie and tie the shoelaces. He is not able to type on the laptop. He is not able to use a screwdriver beta. Can you appreciate what is this phenomena? Person is not able to do fine learned movements now. What is this term beta known as? Remember it is apraxia. Praxia ka matlab movement, apraxia. So there is problem in fine learned movements. Very good. You must have done better in medicine, in neurology, in CNS examination. We do this test now. We show some objects to the person. Like I show this object pen to the person. I am asking to identify this pen. Person is not able to identify. Beta, what is this known as? This is known as agnosia. Person is not able to identify objects. Okay, and sometimes the person may not be able to even identify beta faces. This question again was asked in your exam. What is the term we use when the person is not able to identify faces? What is the term beta? That is known as prosopagnosia. Again beta, please see this. Whenever you are seeing such question, now always read the terms very carefully. Sometimes the answer is there in the option C. Even in this term prosopagnosia, the term has agnosia in the end. So when the person is not able to identify the faces. So please remember. So patient is having, two or more of these cognitive impairments. So in dementia, we are saying there is only cognitive impairment. So is this point clear to everyone beta? Let's complete this table, then I'll move forward towards dementia wala topic more. Okay, is this point clear to everyone? Now please see this. Now the third category. See, delirium mein we were saying both consciousness and cognition is impaired. In dementia only cognition is impaired. In amnestic syndrome, can you appreciate? Out of cognitive functions beta, only it is only the memory which is getting affected, that too recent and remote memory. So if only memory is getting affected, then the diagnosis beta which we are making is amnestic syndrome. Is it clear to everyone beta? Acha, I'll repeat again once more. See again this table. Beta, delirium mein I am saying both consciousness and cognition is impaired. In dementia only cognitive functions are affected, only cognition, these symptoms are there. While in amnestic, see the name is telling you amnesia, only it is the memory which is impaired. Let's finish amnestic syndrome, then I will move to dementia. See, there is one important cause. So I have given you a list of beta causes for amnestic syndrome. See here, it can be so many CNS causes may be there like seizure, trauma or tumors, and even systemic causes. But one important cause, remember, alcohol induced amnestic syndrome. Can anybody tell me what is this known as? We'll discuss this again in alcohol wala topic. Alcohol induced amnestic syndrome is known as what beta? Starts with K. We will discuss this point beta. It is also, please remember, it is Korsakoff syndrome. Please remember Korsakoff syndrome. And actual culprit beta is not alcohol. What is the actual cause? Remember, the actual cause of Korsakoff syndrome is deficiency of vitamin B1, that is thiamine, which we'll discuss. So again, when I'll discuss Korsakoff syndrome with all of you, I will ask you again, what is important finding in Korsakoff syndrome? You will say, sir, it is alcohol-induced amnestic syndrome. So patient has amnesia. Is it clear to everyone? And there are so many other causes. Even I can say thiamine deficiency because of any other cause can also cause amnestic syndrome, and so many other causes. Is it clear to everyone beta? Please see this again. So we have discussed delirium, we have covered amnestic syndrome, and now we will focus on dementia, right? Please remember this. Korsakoff syndrome, also previously known as Korsakoff psychosis, right? See, so in dementia, beta, can you appreciate, we have made the diagnosis of dementia based on the impairment of cognitive functions. But just like in delirium, we know there are so many other symptoms like delusions can occur, motor abnormalities can occur. Similarly, dementia may be beta kuch additional symptoms, you can remember it with additional symptoms. Beta, देखो main diagnosis के लिए we are saying to make the diagnosis of dementia, what is required? Cognitive impairment. But patient may also have some additional symptoms, or you can say neuropsychiatric symptoms. For example, even in dementia, person may have personality changes, especially remember we discussed kaun sa lobe affected, which may also be associated beta. Beta dekho, delirium, you have understood now. First understand delirium, then the cause may be so many. It could be because of hepatic encephalopathy, it could be because of head injury. Even with alcohol withdrawal, patient will develop delirium. But when I say alcohol withdrawal delirium, what important finding or symptom should come to your mind now? See in the question, are they saying that patient has impairment of consciousness? So this is the clue for you. When I will discuss alcohol withdrawal symptoms now, then I will discuss delirium tremens. So tab मैं आपसे again I'll ask you कि बेटा कौन सा finding will tell you कि now it is delirium tremens? You will say sir impairment of consciousness if patient has developed, then I am thinking of delirium tremens. Is this point clear na? हाँ, please remember this. ठीक है? हाँ, in frontal lobe abnormalities you can see personality changes. But a patient can also develop, see, even in dementia, patient can develop hallucinations, delusions, agitation. So can you tell me, see, kaun si hallucination? Again you can say sir visual hallucination, even other can also occur, delusions can occur, agitation can occur. But can you tell me any use of identifying this symptom in the patient? But हमने diagnosis dementia का कैसे बनाया था? With cognitive impairment. But I am saying my patient has also developed hallucination, delusions, agitation. Tell me, will it affect my treatment also? Or if I ask you, beta, is there any role of antipsychotics in the patient of dementia? Yes or no? You will say, yes sir, we can use antipsychotics, very good. For example, if hallucinations, delusions have occurred, agitation is so severe that we may have to give some drugs. So again, we may use antipsychotics. So we are not giving antipsychotic per se to to treat dementia, but we are giving to treat these additional symptoms or neuropsychiatric symptoms. Sometimes you will see, but a patient may also develop depression or many given anxiety symptoms. So is there any role of antidepressant beta in the management? Yes. Suppose patient has developed depression, patient has developed anxiety disorder, so then we can also use some of these antidepressant. So please see this beta. So sometimes they may just ask you, is there any role of antipsychotics in dementia? So yes, for managing these additional symptoms. Is it clear to everyone beta? Now we will discuss, see again I'll show you this table. Let me know if this is clear to everyone, then we'll move forward, then we'll discuss some important causes of dementia. Okay, clear to everyone? Very good beta. I hope clear to everyone. And now let's now discuss a very important topic beta, dementia. Very good. See, dementia, as we have discussed beta, it is progressive cognitive impairment. Please remember, not just memory, but it is cognitive impairment. Memory is a part of cognition. Okay? And we are saying in clear consciousness. Beta, why I am saying in clear consciousness? Because you will say, sir, if the consciousness is impaired, then I am thinking of delirium. So one very important difference beta, please remember one very important difference between delirium and dementia we have already discussed beta. In delirium, the consciousness is impaired, while here we are saying that the consciousness is intact. And of course, dementia, dekho, usually we are saying it is progressive, but there are some reversible causes also which I will discuss. I will give you one table. Also remember beta, agar main aapse puchu, dementia also with respect to age, it increases or decreases, prevalence increase hota hai ya decrease hota hai with age? You will say sir with age. So it increases with age, hai na? As the age increases, the prevalence increases. Okay, so similarly, just like we discussed, even delirium may elderly what has a higher risk, even in dementia we are saying elderly may be at a higher risk. Let's take up some controversies beta now. Let's discuss some important types. So dementia beta, you have identified, see, always identify the terms. Dementia means cognitive impairment. It could be because of many reasons. It could be because of various causes. So let's now discuss some important causes. Okay. Tell me, if I ask you, beta, overall most common type of dementia kaun sa hai? Beta, most common type of dementia, if I ask you, overall is what? Please remember, it is Alzheimer's disease. Very good. Slightly controversial, but now I'm sure all of us can answer this beta. Abhi second most common overall cause of dementia kaun sa hai? Earlier it used to be vascular, but now it is what? This is a topic which is being asked again and again in your exam. Beta, please remember now it is Lewy body disease. Okay, and vascular dementia you can say now as the third most common, vascular dementia. Okay, please remember this. Okay, so Lewy body dementia, very important now, it is the second most common cause of dementia. Okay. See, usually I am saying that dementia is a disease of early age or late age. It is a disease of early age or late age. You will say, sir, it is a disease usually of a later age. But sometimes it may occur at an early age. But that is known as early onset dementia. That is known as early onset dementia. So can you tell me onset? Can you tell me onset before what age is known as? Onset before what age is termed as early onset dementia? But any guesses you would like to make? Onset before, very good, it is before 65. See, if it is occurring before 65 years, then we are saying it early onset dementia. Again, if I ask you beta causes of early onset dementia, most common cause remains the same, it is Alzheimer's disease. Second most common, again slightly controversial, but one you can remember at least, starting with P. Starting with P. It is not Parkinson disease dementia. Please remember PIC disease. But again, this question was asked in one of the INI-CET exams. Tell me, PIC disease is cortical or subcortical? So we know dementia can be divided into cortical and subcortical dementia. See, if you know another name of PIC disease, you can answer this question. So we know PIC disease beta is also known as frontotemporal dementia. Frontotemporal dementia. So you will say, sir, the name is telling us that it is the frontal and the temporal lobe which is getting affected. So it is a cortical dementia. Okay. So please remember this. Okay. See, we are saying that usually the dementia is having, it's progressive and also it usually has an insidious onset. But remember, a vascular dementia ka matlab kya hai? Brain mein there is some vascular event. Okay, like a stroke, there is a hemorrhagic stroke or there is a infarct. So usually vascular dementia is one of the dementias which has a acute onset. It has a sudden onset. It has a acute onset. I hope this is clear to everyone. Let's now discuss some important table beta. Let's discuss this table. So we are saying that dementia usually it is progressive beta, but there are, write down, around 10 to 15% of the causes beta which are reversible. Beta reversible ka matlab if you identify the cause and you treat it, the dementia would be reversed. So let's discuss this table beta. Very important questions have been asked from this table also. So there may be neurosurgical conditions such as SDH. Beta, what is SDH? Subdural hemorrhage or hematoma. Even intracranial tumors, abscess ki wajah se beta there is dementia, you correct it, treat it, dementia would be reversed. And again please highlight this NPH. What is NPH beta? NPH is normal pressure hydrocephalus. Normal pressure hydrocephalus. Again, how do we treat? We treat by ventricular shunting. You treat it, dementia would be reversed. So there are some neurosurgical conditions. Then certain infections such as encephalitis, meningitis, that can also cause dementia. You treat it, dementia would be reversed. Beta, this question came in your exam that a elderly person developed cognitive impairment. So beta, elderly person developing cognitive impairment, so they are hinting towards dementia. They had asked deficiency of which of the vitamin may cause dementia. But if they ask you one important vitamin, now please remember vitamin B12, very very important. Even other vitamin like folate, niacin, even thiamine, they can also cause reversible dementia. You correct it, dementia would be reversed. But one question has already been asked beta. If I ask you from the endocrinal abnormality beta, if they ask you one important endocrinal abnormality, please remember hypothyroidism. Even hyperthyroidism, even hyperparathyroidism, they are also associated with reversible dementia. Beta, even remember in fact a substance alcohol, chronic use of alcohol se bhi beta dementia ho sakta hai. You tell the person to stop alcohol, even the brain changes which have occurred after stopping alcohol within a year, even those changes may be reversed. So alcohol can also cause reversible dementia. So please remember this table. Many questions have been asked from this table. One new question may come like this beta. A patient you are suspecting to have dementia or cognitive impairment, which investigation would you like to do? Would you like to do brain scan, vitamin B12, thyroid function test, or all? So in that question you can say all, because you are trying to rule out some of these reversible causes. But I hope this is clear to everyone. Very good. So let's take a small break. We'll take a break of around 15 minutes and we'll again start at 12:15. Okay, beta? So we'll start at again. Let's take a 15-minute break and we'll restart at 12:15. Okay. Meanwhile, if anybody has any doubt, beta, you can ask. Okay. But I'll repeat this. So I am saying you're suspecting a patient having dementia. They are asking you which investigation would you like to do. Would you like to do a brain scan? Maybe to rule out some of these neurosurgical condition. Yes, you may also like to do vitamin B12 levels, also thyroid function test. So one of the option may be all. So you may do all of these tests. Okay. Right. So let's take a break and then again we'll meet. So right, let's restart again. Welcome back after the break. So let me first take up few queries better which I can see in the chat. Let me just take up some queries. Just let me know if I'm audible and visible. But I'll mark the PYQs, don't worry. I'll share, I'll put a question mark or I'll write PYQ when I'll share the PDF, no, don't worry. Also now I'll write down the PYQ, but I will discuss the difference between echolalia and perseveration abhi when I'll touch upon the topic of echolalia. Yes, beta delirium may, but after meningitis, let us say after encephalitis, the person may develop delirium, and let us say chronically because of the infection, later on the person may even develop dementia. And yes, sometimes even later on the person may develop some psychotic symptoms, even during the illness also. Remember we discussed even during delirium, even during dementia we discussed person may develop some of these symptoms like delusions, like hallucination. Yes, right. So I hope it is clear now. So we are good to go. Very good. So let's now continue with the discussion of dementia. We have discussed one table of reversible causes, but this is very important. Many questions have been asked from this topic in various exams, and they may ask newer questions also. Let's now discuss better also one more classification. See, sometimes we divide dementia on the important site of lesion. See, there is cortical dementia and subcortical dementia. So in cortical dementia we are saying it is the cortex better which is getting affected first, while in subcortical dementia it is the subcortical areas such as the basal ganglia, thalamus, cerebellum, these areas are getting affected first. So can I say the cortex is getting affected first, it is the site of lesion, while here we are saying it is the subcortical region which is getting affected first, but later on better even the other areas may also get involved. So we are saying in the initial part of the illness which area is getting affected first. But the question which is asked more often is the examples. Beta, can you tell me the example, beta? Can you tell me some examples of cortical dementia? One very important example is Alzheimer disease. Alzheimer disease. Okay, somebody has asked, बेटा organic mental disorder देखो पुरानी classification है तो उसमें organic को अलग रखा हुआ है and then functional में neurosis, psychosis. ठीक है? Can you tell me one more cause, बेटा, which we have already discussed, बेटा? Can you tell me one more cause? One more cause, बेटा, which we have already discussed before the break. Remember, Pick disease. Pick disease. It is also known as frontotemporal dementia. So the name is telling you it is the cortical areas, frontal lobe and the temporal lobe which is getting affected first. Also, can you give me better some important examples of subcortical dementia? So you can say, sir, Parkinson disease dementia. In Parkinson disease also person may develop dementia. Even Huntington's disease, even in Wilson's disease, the person may develop, even in multiple sclerosis, and so many other causes are there where the person may also develop dementia. But beta, can you appreciate, like in Parkinson disease, usually we read initially the person has developed such symptoms like there is tremors, there is rigidity, there is bradykinesia. Huntington disease patient may develop Huntington's chorea, coriform movement. Even Wilson multiple sclerosis patient may present to us initially with a lot of motor abnormalities. So beta, can I say, very important point, beta, can I say that motor system usually is normal in the cortical dementia in the initial stages, while it is abnormal or it may see a lot of motor abnormalities in the initial phases? Can you tell me why? Beta, this is a very important point which I am discussing. Can you tell me why that in subcortical causes of dementia you are seeing a lot of motor abnormalities in the beginning? So you can say because our areas such as basal ganglia, they are getting affected first, so which are related with the movement. So please remember this point, very very important. So they may just give you a clinical scenario in which patient started with some motor abnormalities and patient also developed cognitive impairment. So then you are thinking of subcortical dementia. But also, can you tell me where will you place vascular dementia, where will you place Lewy body dementia in this table? कैन यू टेल मी? बेटा हमने वो डिस्कस किया था ना, सेकंड मोस्ट कॉमन, थर्ड मोस्ट कॉमन कॉजेज में हमने डिस्कस किया था, बेटा उनको कहाँ प्लेस करोगे? यू कैन राइट डाउन बिलो दिस. Some of these causes may have mixed features, very good, such as vascular dementia, very good. But vascular dementia में the vascular event can occur in the cortex and even in the subcortex. Also we'll discuss Lewy body disease. Both regions may be affected. In fact, when I'll discuss the core features in the next slide, we'll correlate this point. But I hope this is clear to everyone now. I'll discuss now one of the very important causes, but this is a very important topic. Let's discuss some important points about dementia of Lewy body or Lewy body dementia. See, there are 4 core features in Lewy body dementia. See, as we discussed, the cortex and the subcortex are getting involved. So if the cortex is getting involved, I'll say cognitive functioning is getting affected. And if the subcortex beta involved ho raha, so we can say motor features. So there are 4 core features which you can remember with the mnemonic beta CVMR. So let us say there is a person, Mr. Louis, he goes for an interview and the interviewer asked Mr. Louis, show your CV, Mr. So CVMR. So what is C? First is beta, there is fluctuating cognition. So there is cognitive impairment and that is also fluctuating. Okay. So there is alteration in attention, there is alteration in alertness. So there is fluctuating cognition. But can you appreciate, we have been discussing that which hallucination is more common in organic disorder? You will say, sir, it is visual hallucination. See, and it is there in the core feature. So visual hallucination. And we discussed that it has mixed features. So agar subcortex beta involve hoga, can I say person would develop motor features of Parkinsonism, right? So person may develop tremors, rigidity, bradykinesia. Okay. Please highlight this. This may come as a new question. But now there is a fourth core feature which is included in this list, which can come as a new question. Remember, REM sleep behavior disorders. So there are NREM disorders, there is REM disorder. So REM sleep behavior disorder, one of the REM disorders is included here. So please remember, beta, these are the 4 core features of Lewy body dementia. Is it clear to everyone? Beta, remember the mnemonic CVMR. Now let's discuss, beta, there are also some supportive features as well. Supportive feature means that if the person has these features, it is supporting the diagnosis of Lewy body dementia. One of them is, beta, patient with Lewy body dementia, they are sensitive to antipsychotic induced EPS. What is EPS? Extrapyramidal symptom. See, we know patient may develop hallucinations such as visual hallucination. And suppose we gave antipsychotic, and let us say patient comes to us like this. Patient says, sir, I am not able to move my neck. My neck is twisted to one side. But this is which EPS? We will discuss a list of EPS. This is acute dystonia. So please remember, these patients are at higher risk of developing EPS. So one has to be careful when you are giving antipsychotic. We may give antipsychotic which has lower potency for causing EPS. Also remember, person may have repeated falls. There is syncope. So they may give you that patient has history of repeated falls, syncopal attacks. Which dementia you are thinking? Again, it could be Lewy body dementia. Patient may also have beta autonomic disturbances. So severe autonomic dysfunction can be seen in the patient. You will see that the blood pressure is fluctuating, pulse rate is fluctuating. So a lot of autonomic fluctuations may occur. Also patient may have delusions such as delusion of persecution. Can you tell me one more important delusion? Can you tell me one more important delusion, beta, which can occur? Close person replaced by stranger. I am giving you a clue. In fact, this is a PYQ, beta. This question was asked. This question was asked in your exam. A person presents with Capgras syndrome. Remember, we have discussed this point now. So the question was, a person present with Capgras syndrome, which dementia you are suspecting? So sometimes we see that in Lewy body dementia, patient may develop Capgras syndrome. So these are some supportive features of Lewy body dementia. Also in the pathological finding, beta, this question has been asked in the exams as well. So they had given, I'll discuss about that question. First, let's see what is this pathological finding. Can you appreciate this pink core surrounded by a halo? Beta, what is this finding? So see the name will tell you. So the name is Lewy body dementia. So these are what, beta? These are Lewy bodies. Please remember. So Lewy bodies are seen. Very good, beta. Please remember. So Lewy bodies can be seen. Very good, beta. These are alpha synuclein bodies. Very good. Now very important, remember this point that these Lewy bodies can also be seen. Can also be seen in which more one important condition, beta? Can you tell me? They can also be seen in Parkinson disease. Very good, beta. Parkinson disease. In fact, beta, remember this very important point, and finally this question came in your exams in January 2026. So remember, Lewy body dementia, Lewy body disease has a close differential diagnosis of Parkinson disease dementia. Please remember this very important point. And finally, beta, we have been discussing this as an FQ, and this question came in January exam. See, so we are saying that, beta, in Parkinson disease dementia also patient has motor features, visual hallucinations can occur, fluctuating cognition can occur, so cognitive impairment is occurring. So that is why we are saying that it is Parkinson disease dementia. And we are also saying that Lewy bodies are seen in both. So can you tell me, beta, how would you differentiate? Usually in the exam, beta, they have asked this question and they had not given Lewy body dementia in the option. So next one of the differential diagnosis is Parkinson disease dementia. But suppose they give both the option in the question, beta, kaise differentiate karoge? See, the answer lies in that classification of cortical and subcortical. I am giving you a very important clue, beta. Now can you tell me how would you differentiate? You will say, sir, Parkinson disease dementia is a subcortical dementia. Here you will see motor features, motor symptoms are present, and after that cognitive symptoms would develop. In fact, the research criteria uses 1 year duration, beta. After motor symptoms development, 1 year later the cognitive symptom would develop. While in Lewy body dementia, beta, remember the cognitive symptoms are occurring in the beginning plus minus motor symptoms. Motor symptoms may occur in the start or may occur later on. So this is a very, very important point. Please remember this point. Okay. So these are some important points about Lewy body dementia. Very important topic. Please remember this. Let's now talk about the management. Let's now discuss beta about the management of dementia. Okay. This again is a very important table which we'll discuss. So let's discuss the management. See, in the management, one important screening tool which we can remember is mini mental state examination. See, this is MMSC, not MSC. MSC is the examination of a psychiatric patient. This is MMSC. So this is a screening tool, but it hardly takes 10 to 15 minutes and we can apply this screening tool. This is for assessing cognitive function. Please remember this point. So we assess a lot of cognitive functions by MMSC and we get a total score. But what is the total score? What is the total score of MMSC? Remember, it is 30. And we say anybody scoring less than 24, it is suggestive of dementia. We are not saying we are making a definitive diagnosis, but it is suggesting that probably the patient is having cognitive impairment. So patient may be having dementia. We may have to assess the patient more, now in a more elaborative manner. And this was given by Falstein et al. This was given by Falstein et al., also known as sometimes Falstein test. Okay, so MMSC. But please remember, it is assessing cognitive function. Suppose they tell you that a patient after the road traffic accident, but please hear this question carefully. After RTA, road traffic accident, 2 days later, patient is confused, patient is disoriented. Patient is confused, patient is disoriented, and they also give you MMSC score is 20. Can you tell me now the diagnosis would be? Please don't get into such traps. So I'm also trying to tell you some important traps. Beta, यहाँ पे क्या diagnosis बनाओगे? Everyone please tell me what diagnosis would you make? RTA after RTA 2 days later, confused, disoriented, MMSC score also given. Very good beta, यहाँ पे diagnosis would be delirium. Don't get confused with the MMSC score. See, MMSC is actually assessing cognitive function and cognitive function is also affected in delirium. So please see, patient is confused, he is disoriented. So they are hinting towards acute onset, there is impairment of consciousness, they are hinting towards delirium. Okay, is it clear now? Now, in the management of dementia, beta, let's come. First important point beta I have mentioned is treat the cause. Why have I mentioned beta treat the cause? Because we know that there are some causes which are reversible. So please identify if the patient is having any reversible cause and treat it, because we can reverse some of those causes. Let's discuss about the pharmacotherapy, and this is a very important table. Beta, let's discuss 3 important categories of drug which we'll discuss for the management of dementia. And I always say beta don't mug up the mechanism of action of these drugs, always try to correlate with the etiology. Let us say, for example, let's take Alzheimer's disease. Alzheimer's disease, we know it is the most common cause of dementia. It is a cortical dementia. Onset usually is slow, is insidious. See, if I ask you, this question in fact was asked in your FMG exam. A patient develops Alzheimer's disease, it's a PYQ also. Which of the neurotransmitter beta is reduced? So can you tell me which important neurotransmitter? Very good. So you remember it, Dr. Goel, very good. So which important neurotransmitter beta? We know acetylcholine is reduced, right? So we are using one category of drug beta which is choline esterase inhibitors. It inhibits the enzyme acetylcholine esterase. So this enzyme basically it breaks down acetylcholine into acetyl-CoA plus choline. So beta agar हमने इस enzyme को we inhibited this enzyme, so can I say acetylcholine will increase, isn't it? So this is one of the drugs which we use. So some drugs in this category beta, remember, one is tacrin, which is not used much nowadays. Why? Because of one important side effect. Can you tell me important side effect? It can cause hepatotoxicity. Okay, because of hepatotoxicity. Then we have some drugs beta, please remember, donepezil, remember donepezil, rivastigmine and galantamine. Very good. So please remember these names, donepezil, rivastigmine, galantamine. Usually the patient comes to us with dementia and usually these are one of the first drugs which is started. Now this question was asked in one of the INI-CET exam, but please be careful with these PYQs, that after starting choline esterase inhibitor, person develops GI symptoms. Which of these drugs would you use? So can you tell me any of these drugs which is also given through other route other than oral route? Please remember rivastigmine also can be given through transdermal route. Very good. It is available as transdermal patch. And in fact one important drug update beta, kaun sa drug hai wo? Since they've asked this side effect, GI side effect beta, they may just ask you this newer drug. So in today's discussion I will also give you a lot of newer drugs which you should have in your list. Okay, so which is that drug I'm talking about beta? Remember it is Benzgalantamine. Please remember, it is benzgalantamine. It is a oral drug. It's a oral drug beta, which has less GI side effects. Okay, so please remember that is benzgalantamine. So this is one category of drug beta. Suppose if I ask you, tell me one more important neurotransmitter beta. This also we discuss in the classes now. Tell me one important neurotransmitter, one more starting with G, which is also implicated in dementia like Alzheimer's disease. Please remember, this is glutamate. Now tell me from your biochemistry knowledge, glutamate is inhibitory or excitatory? So you will say, sir, it is excitatory. In fact, glutamate initially is increased. So it causes excitatory damage to the neurons. So the next category of drug beta which we have is mementin. What is mementin beta? What is the mechanism? Now you can correlate. It is a NMDA antagonist. It is a NMDA antagonist. And can you appreciate N-methyl D-aspartate? This is which neurotransmitter receptor beta? Glutamate. It is a glutamate receptor. So can you appreciate, we are saying glutamate is increased, so we are using NMDA antagonist. And finally beta, this question was asked in the January 2026 exam. Okay, so again you will see many questions being asked from this table. Okay, so mementin usually we use for moderate to severe cases. And can we combine mementin beta? Can we combine mementin with drugs, cholinesterase inhibitors like donepezil? Yes, they can be also combined. So please remember. So we have two important categories of drugs beta, but remember these two categories of drug, they don't cure the person, they slow down the disease progression. But now we have one more category beta. This again can come as a new question. So FDA has approved one newer class of drugs. So let's discuss another important category. See, again let's correlate with the etiology beta. What is this? What are these deposits in the brain of patient, especially for Alzheimer's disease beta? These drugs are used. These are A beta deposits. These are A beta deposits. Okay, these are amyloid plaques, A beta deposits. So these monoclonal antibodies beta, what they do? They bind. So these are antibodies beta, they bind to these A beta deposits and they help in their clearance. So this is a newer category of drug beta which is approved, especially beta. Abhi tak jo first two categories we discussed can be used for other causes of dementia, but monoclonal antibodies beta, please remember they are used specifically for, very good, for Alzheimer's disease. Very good, especially mild cases of Alzheimer's disease. And this is how beta you are going to remember. See, the name you can remember from this, only from the name Alzheimer's disease beta. So we have three drugs, one with A, aducanumab. Mab matlab monoclonal antibody. Aducanumab. Can you remember the name? Yes, you can. So aducanumab. Second is with L beta, lecanemab. Can you remember the name? Yes, you can. And one more name beta you can remember, that is D for donanemab. Is it clear to everyone? Please remember these names, and these drugs are given through IV infusion. Through IV infusion. So these are the three important categories beta of drugs which we have discussed. Very important. You may get questions from this. They have already asked question from these two categories. They may also ask some newer question from this category. Especially beta remember lecanemab. I hope this is clear to everyone. So we have discussed a very important topic, that is neurocognitive disorder. Again, highlight this table. Very important. Okay, let me discuss few questions and then we'll discuss the next important category. So let's see, beta, this was the question I was talking about. See, this is again your January ka exam question. Please remember, this is the January exam question. Very simple now. Elderly patient diagnosed with dementia on drug mementin. So given the name mementin, you have to just tell the mechanism. So we know beta, in fact both the points they have given, it is NMDA blocker and which neurotransmitter acts, it is acting by the glutamate. Very good beta, please remember. Is it clear? Now see this question beta, finally this question was also asked in the exam. A female, elderly female is brought to the psychiatry OPD by her daughter, complains of forgetfulness. So there is cognitive impairment, forgetfulness is there. For the past 1 year, she has been seeing people and animals in a nearby house that has been unoccupied during this period. So she is seeing things not seen by others. So can I say the patient has also developed a bit of visual hallucination, and also now she has developed rigidity. You have to tell me most likely diagnosis. But can you appreciate? Beta देखो फिर से देखो, it is not frontotemporal dementia. Beta देखो, patient has developed cognitive impairment beta, visual hallucination, and patient has also developed motor features like tremors, rigidity. Okay, so tell me, is it, see, is it Lewy body dementia or Parkinson disease? See, both they have mentioned now. So can you appreciate the motor symptoms are occurring slightly later on. So here the answer is, finally they've asked this question also. So यहाँ पे बेटा answer क्या है? It is Lewy body dementia. See, in frontotemporal dementia, please don't confuse with frontotemporal dementia. We know that frontal lobe may be affected more in some causes, and some there may be more temporal lobe which is affected. So when frontal lobe is affected, beta, we see a lot of behavioral symptoms, है ना? We see a lot of behavioral symptoms like disinhibition may be there. There may be emotional dysregulation, and if temporal lobe is getting affected, language impairment may occur more. Okay, so here the answer is Lewy body dementia. Please be very careful beta when you are answering. यहाँ पे इन्होंने दोनों option दिया था. So answer would be, it is Lewy body dementia. So let's now talk about, so we have covered a very important topic, that is organic disorders. Let's now start with the psychotic disorders. So let's now start with the next important category of disorders beta, that is psychotic disorders. Okay, very good. Yes, but again, you know, slightly later on, again just the hint is that now the person is also has developed rigidity, and so maybe from the history they are trying to tell you that now the symptoms have developed later on. So this is one of the clues they are trying to give you, that now it is Lewy body dementia, because we discussed that in Parkinson disease initially it would be motor symptoms, because we discussed Parkinson disease dementia is a subcortical dementia. Their motor symptom would occur first, and later on research criteria uses 1 year duration. After 1 year of start of motor symptom, then there will be cognitive symptom which will develop. Okay, right. So let's start with the psychotic disorder. So we'll discuss first very important topic, which is beta schizophrenia. Okay, up till now beta everything is clear now. Then we'll move on to this very important topic of schizophrenia. Okay, then we'll discuss in the end some other psychotic disorders also. See, everything in schizophrenia, yes beta, Hirano bodies, that can also be seen. Yes beta, Hirano bodies beta, again you would read in pathology also, Hirano bodies, they are made up of actin, so they are also seen as a finding in the Alzheimer disease patient. So in Alzheimer disease in pathology beta, can you tell me? Okay, so tell me some important clinical findings beta, quickly tell me. In Alzheimer disease, some important pathological findings. What all pathological findings we see? There is amyloid plaque or neuritic plaque or senile plaque made up of A beta deposits, right? Then we have neurofibrillary tangles. What are these made up of? Which protein? Hyperphosphorylated tau protein. And then we also have beta Hirano bodies. Hirano bodies, they are made up of actin. Okay, so these are some pathological findings, some pathological microscopic findings which we see in Alzheimer disease. Very good beta. Okay, so let's now discuss schizophrenia. See, everything in schizophrenia is important. Let's start from the history. So you know, so many years back the concept of schizophrenia was not the same as it is right now. So let's discuss few people. First important person beta we'll discuss is Emil Kraepelin. Kraepelin identified some patients and he coined the term dementia precox. It's a PYQ beta, it's an old PYQ. Who coined the term dementia precox? It was Kraepelin. So now when we see description of those patients, it appears he identified schizophrenia at that time, but उन्होंने नाम क्या दिया? He coined the term, it was dementia precox. Then came another gentleman, but again very important, Eugene Bleuler. Bleuler is the person beta who coined the term schizophrenia. Please remember. Okay, he coined the term schizophrenia. Beta, schizo means split. Schizo means split. Phrenia means mind. It was his understanding that there is a split in the mind. But we'll discuss now what is the current concept. Tell me, beta, is schizophrenia same as split personality? Yes or no? Tell me, beta, is schizophrenia same as split personality? Please remember, no. Split personality we will discuss under the heading of dissociative disorder. The meaning of the name schizophrenia is split mind. Okay, please remember. Now, Eugene Bleuler ने बेटा coin किया term schizophrenia. So then he also gave the symptoms, which we say as Bleuler 4A's. So he gave 4 important symptoms of schizophrenia, which are termed as Bleuler's 4A's. In fact, many of these we have already covered. But please see this. First is association disturbances like loosening of association. But where we have discussed this today? Remember, loosening of association we have discussed in the formal thought disorders. Next A beta is affective flattening. So we have already covered na, flat affect may be seen in schizophrenia. Next is beta autism. Here autism means that the person has beta illogical thinking. The thinking is not showing logic. I'll show you one question. So there is illogical thinking. The person has fantasy thinking. And one more A is beta ambivalence. Can you tell me beta what is the English meaning of ambivalence? Sometimes in the morning when you're not able to decide should I wear red dress or white dress, you say sir I'm being very ambivalent. So ambivalence का मतलब क्या है बेटा? Inability to decide. at the level of thinking. Beta, for example, let us say there is a pen on the table. टेबल पर बेटा एक पेन है एंड इन द माइंड द पर्सन इज थिंकिंग, स्टेयरिंग ऑन दिस पेन फॉर आवर्स एंड आवर्स, थिंकिंग शुड आई पिक इट अप और नॉट. तो ये क्या है बेटा? दिस इज एम्बिवेलेंस. सो प्लीज रिमेंबर दीज आर टू इंपॉर्टेंट कॉन्ट्रीब्यूशन ऑफ यूजीन ब्लॉयलर. ही कॉइन्ड द टर्म schizophrenia and he gave Bloiler 4 A's. Is it clear? Let's discuss one more gentleman, Kurt Schneider. So Schneider said, let me increase the burden of students. So he gave in fact 11 symptoms, and those are known as beta Schneider's first rank symptoms or SFRS. But don't worry, many of these symptoms we have already discussed. So let's discuss some of these Schneider's first rank symptom. Again, this is very important, but nowadays they may just ask question from the history also. We'll discuss some clinical questions. See, what is the first symptom? See, we know that person can have hallucination, auditory hallucination, and auditory hallucination may be beta, there can be different types. One of the first symptom beta is audible thoughts or thought echo. Beta, यहाँ पे the patient says that he can hear his own thoughts. Beta, normally all of us know our thoughts na, any thought which is coming in your mind, you know that thought. But patient says, sir, when I am having a thought in my mind, I also hear a voice which is repeating that thought. तो बेटा इसको क्या कहते हैं? Audible thought या thought echo कर रहा है. In fact, बेटा this is which hallucination? This is first person auditory hallucination. Next is beta voices arguing or discussing about the patient. Patient says, let us say beta if this is the patient, patient says, sir I can hear few voices which are talking to each other. बेटा आपस में वो आवाज़ें बात कर रही हैं. Which patient says I can hear. So this in fact is an example of third person auditory hallucination. So he can hear voices, 2-3 voices which are talking amongst themselves, which he can hear about the patient. So this is what? This is third person auditory hallucination. Also voices commenting on one's action or giving a running commentary. But just like when you're watching cricket match, commentators keep on commenting whatever the players are doing na? Like the commentators may say, now the bowler is ready, bowler has bowled the ball, now batsman has hit it for a 6. Similarly, patient says, sir I hear a running commentary that when he wakes up he hear a voice, now he has got up from the bed, now he is going to the washroom, now he has come back, now he is preparing his meal, he is getting ready. So patient says, sir whatever I am doing I am hearing a running commentary. See, this voice is not directly talking to the person na? So this is also an example of third person auditory hallucination. So please be very careful, but this is a very important point which I will discuss. So can I say that the first 3 are auditory hallucinations which are included in the SFRS? Yes or no? Please remember this beta. Also now if I ask you, tell me true or false, auditory hallucination is SFRS, true or false? You will say, sir it is partially true because not all auditory hallucinations. Somebody is hearing dog barking. Yeah, somebody is hearing a voice directly talking to the person. So this is second person, that is also not included here. But please be very careful. They may just give you question. This is having a historical significance, but they may ask question like this. So they may give you example of 4 auditory hallucination and they may ask you which of the following is more suspecting towards schizophrenia. So again from the history you can say, okay, if any of these hallucination is from these 3, then you can say it is maybe suggesting of schizophrenia. But now we know in schizophrenia beta any hallucination can occur. But is this point making any sense beta? Please be very careful. Let's discuss the next 3 beta. Thought withdrawal, thought insertion, thought broadcast. This we have already covered now, that somebody is inserting thoughts or withdrawing my thoughts or broadcasting my thoughts. So this we have already covered kahan pe? Under thought alienation phenomena beta or passivity of thought. Very good beta. Is it clear now? So first 6 we have covered. Very good. Yes, group discussion. So yes, you can say in third person auditory hallucination. Yes. Now next 3 beta are made phenomena which you can remember with the mnemonic IFA. देखो Bollywood में there are IFA words na, so let's remember it with IFA. Made impulses, made feelings, made acts. See, the name itself is telling you beta, made, this phenomena is telling you that someone is making the person experience it. So patient experiences that the impulses. What are impulses? Urges. He says I am having some urges but these are not mine. Somebody is making me experience them. Or person is crying, you go and ask the person why are you crying. Patient says, sir this feeling of crying is not mine. Somebody is making me experience it. Or let us say one patient has slapped another patient, you go and ask what happened, why did you slap? That person says that this action is not done by me. Somebody has made me do it. So this is made acts. So the feelings, impulses or acts are not mine, somebody is making me experience. So beta, this is the meaning of made phenomena. Let's discuss the last two entities, but again don't mug up anything, just see the name. One is somatic passivity, just see the name. Beta, what do you mean by somatic? Beta, somatic means bodily sensation, and passivity I already told you in the morning. Now passivity means it is influenced or it is under someone else's control, imposed upon by an external agency. So person is experiencing a somatic bodily sensation which he says is because of an external agency. So let's bring one patient in the class. So let us say we have a patient, Mr. Bholu. So Mr. Bholu is admitted with us and he says that, sir, I am having pain in my abdomen. So can I say this is a bodily sensation? So this is somatic, this is bodily sensation, which he says is because of radio waves sent by the aliens. So can I say patient is having bodily sensation which he says is because of an external agency? So what is this phenomena, beta? This phenomena is somatic passivity. Please be very, very careful, hai na? Please remember this. Let's discuss the last important point, beta. That is delusional perception. Please don't be in a hurry. In the exam, when you are in a hurry, you may read this as delusion of persecution. No, this is delusional perception. Again, just see the name, beta. Delusional means that a delusion has developed in the mind of the person. So patient gives a delusional meaning to a normal perception. So patient experiences a normal perception and gives a delusional meaning to it. For example, beta, let us say a person goes in a party and he sees a spoon with a crown over it. But all of us can see this spoon with a crown now. So can I say this is a normal perception? And he starts believing that he stands on the table, says to everyone, kneel in front of me, I am the king of the world. He starts believing he is the king of the world. But what is this now developed? This is delusion of grandiosity. So can I say a normal perception is led to development of a delusion? So this is delusional perception. In fact, beta, this question came in the recent NEET PG exam. A person saw a bird flapping the wings. So this is the normal perception, and he understood it that it is God's way of sending him a signal that he should run away. So can I say, beta, normal perception has been given a delusional meaning. So what was that likely phenomena there? It was delusional perception. So please be very careful, beta. Such questions may be asked. Is it clear to everyone? Right? Now let's discuss, beta. Usually we know that schizophrenia, usually overall if we say males and females, it usually have a earlier onset. But sometimes patient may develop schizophrenia at a later age. But that we say is late onset schizophrenia. But when we say the person has developed late onset schizophrenia, when the onset occurs for the first time, after what age? Can anybody tell me? But onset after what age? Very good. Onset after 45 years of age. If the person develops schizophrenia for the first time after 45 years, then we say it is late onset schizophrenia. And we have discussed this point, beta, in the prognosis. We have discussed that usually late onset schizophrenia has good or bad prognosis, beta. It has very good. It has good prognosis. Very good. It has good prognosis. Let me show you some questions, beta, so that you have an idea what kind of question, beta, may be asked from the history. See this question, everyone. See, this question was asked in a recent INI-CET exam. A patient with schizophrenia says, Lord Hanuman was a celibate. I am a celibate here means, celibate, what is the meaning? Celibate, brahmachari. Lord Hanuman was a celibate, I am a celibate, so therefore I am Lord Hanuman. Now can you appreciate, beta, what is this example of? See, even if sometimes by reading the question you are not able to identify, just see the options, you will be able to understand. Tell me, beta, what is the right answer? Patient says, Lord Hanuman was a celibate, I am a celibate too, so therefore I am Lord Hanuman. So it is not loosening of association, no? You are able to understand things in the question, but the logic is not there. It is not verbigeration, it is not some senseless repetition. But see, celibate is not a neologism wala word, but please be very careful. No? Sometimes they use such English words, so please don't get caught in that. So it is not neologism, but can I say it is autistic thinking now? So it is illogical thinking. Can you appreciate there is no logic in the thinking now? So such kind of questions also may be asked from the history. So please be very careful. Is it clear? Let's now discuss a few points about the etiology, and then we'll discuss the symptoms of schizophrenia. See, in the etiology now, one very important cause in the schizophrenia, beta, we read is the biochemical factors. And one important neurotransmitter involved in schizophrenia is dopamine. Beta, in fact, it's an old hypothesis. So earlier it was believed, beta, that there is increase in dopamine in the brain of the patient who develops schizophrenia. In fact, can you now appreciate, always correlate this with the mechanism of action of drugs. We are saying that dopamine is increased. So antipsychotics beta were developed. What was the mechanism of antipsychotics? One of the mechanism is they are dopamine antagonists. So please remember this. In fact, we will discuss beta that there are different pathways. We will discuss when I will discuss the symptom. But remember, this is dopamine hypothesis. But as our knowledge is improving beta, we know that even other neurotransmitters like serotonin is also implicated, and there is also increase of serotonin. In fact, increase of serotonin is associated with both positive and negative symptoms of schizophrenia. And you can again correlate this with the mechanism of action of drugs. With the second generation antipsychotics का क्या mechanism है? They are not just dopamine antagonists, they are also serotonin antagonist. And in fact, even some of the other neurotransmitters like GABA, glutamate, norepinephrine, acetylcholine, and so many other, they are also implicated, and many of them are reduced in schizophrenia. So these are some important points about the neurotransmitters. But let's discuss now, let's discuss the symptoms of schizophrenia. First is the positive or the psychotic symptom. See, if we correlate this with the dopamine pathway, beta हमने discuss किया that dopamine is increased in the patient's brain जिनको schizophrenia है. There is one dopamine pathway beta, that is mesolimbic pathway. Meso means it starts from the midbrain. It starts from the midbrain, goes to the limbic system. Okay. In this pathway actually beta there is increase of dopamine. So in this pathway actually there is an increase of dopamine which is causing what symptoms? Which is causing positive or psychotic symptom. Beta, can you appreciate now? So we know there is delusion, there is hallucination. Have I mentioned beta which delusion? Have I mentioned any particular delusion here beta? That means, tell me. That means any delusion can occur in schizophrenia. But in fact, if I ask you what is the most common delusion, but if I ask you most common beta kaun sa hoga? Delusion of persecution. Very good. But remember, any delusion can occur. Similarly, any hallucination can occur in schizophrenia. But if I ask you beta most common hallucination kaun sa hai? Very good. It is most common is it is auditory hallucination. Is it clear to everyone? So please remember, one is the positive or the psychotic symptom. Next is we know we have, and please remember beta, usually positive symptoms, they have good prognosis. Okay. So usually when we are using antipsychotics beta, many of these antipsychotics we know they are having dopamine antagonism. So you will see that a lot of these drugs are showing good response to positive symptoms. So it has a good prognosis. Then we have negative symptoms of schizophrenia beta. So we have one more dopamine pathway which is mesocortical pathway. Beta, this is from the midbrain to the cortex. In fact, beta, it is seen in this pathway there is a decrease of dopamine which causes negative symptoms. Okay, and we have some important negative symptom. Let's discuss these negative symptoms beta. This we have already covered beta. What is anhedonia? Remember we discussed anhedonia means there is decrease of interest. So there is a decrease of interest in things which the person used to enjoy before. Beta, can you tell me beta what is avolition? Volition means willpower. So what is avolition beta? Avolition means there is decrease of will or there is decreased motivation. Family members complain that he does not show will or motivation to do any task. Affective flattening beta, remember we have discussed the flat affect. There is decrease of expression of emotions. There is decrease of expression of emotions. So they may give in the question that there are good events at home, there are some sad events at home, no change in the affect. So beta ye kya ho gaya? This is affective flattening. See, asociality, don't confuse this with antisocial. But antisocial means against society. Asocial means there is decrease in socialization. Family members complain, sir, he does not socialize. We take him outside, he does not socialize with others. लोगों से घुलता मिलता नहीं है. People come at home, he does not socialize. So there is decrease in socialization. Next is alogia. Beta, remember we discussed neologism. So new word, logia means word. So what is alogia? So there is decrease in speech. There is decrease in speech or verbal output. So family members say that sir he speaks very less. Very few words he speaks. So these are negative symptoms of schizophrenia. But can you appreciate why we are calling them negative symptom? Because you can appreciate beta everything is getting minus. So these are negative symptoms. And also can you appreciate beta one of the reasons of these negative symptoms is decrease of dopamine. So usually you will see that antipsychotics may not show very good response with negative symptoms. So remember it has a they have poor prognosis. Poor prognosis. Is it clear to everyone, beta? Please remember this. Also, can anybody tell me, beta, this point here only I will discuss. We know, when we talk about the subtypes of schizophrenia, beta, we know one important point, that these subtypes now have been removed. We know that these subtypes have now been removed from schizophrenia. But can anybody tell me, if the patient has predominantly, these delusions, hallucination, beta, what is the name given to this subtype? Beta, there we will not, in autism, beta, we will try to identify them as separate symptoms. They may look similar, but there we will identify what symptom the child is having. Beta, can you tell me, if predominantly in a patient with schizophrenia, delusions, hallucinations are present? So earlier we used to give one subtype. Now, kaun sa subtype hai? We know there are some subtypes now. Remember paranoid schizophrenia. Okay, so they may just give you a question. They may give you a question, beta, jisme patient is having predominant delusions, hallucination, and they may just ask you which is the subtype. Of course, we know that these subtypes now have been removed, but if they want to ask question from subtype, this is one of the question they may ask. Is it clear? And can anybody tell me, if a patient has predominantly, beta, if a patient has predominantly negative symptoms, so which subtype we use? What is the name of the subtype, beta, if the patient has predominantly negative symptom? Remember, we know it is simple schizophrenia. Okay, simple schizophrenia. At least remember these names. Also remember, abhi subtypes have now been removed. Okay, we just call it as schizophrenia. Please remember this point. Okay, so let's discuss now some disorganized symptoms. So there may also be, beta, disorganization symptoms. It could be disorganization in the speech or the thought. Beta, patient ki thinking mein or in the speech there is disorganization, which we have already covered. Remember, formal thought disorders mein humne discuss kiya tha na, that there is disorganization. So can you tell me some formal thought disorders such as loosening of association, such as derailment, tangentiality, neologism? So these symptoms may occur. But sometimes disorganization can also occur at the behavioral level. So person may be showing some bizarre behavior. For example, he tears his clothes, starts dancing in public. Okay, so the disorganization may also occur at behavioral level. Also, let's now talk about, beta, catatonic symptoms. So let's now discuss. Beta, bizarre is something which is very, very gross, very odd. Okay, very gross behavior may be there. Something which you are not expecting, very, very bizarre. Normally, you will not see such behavior. That is bizarre behavior. Okay, is it clear? No, beta, negative na symptoms hai. I am saying that earlier we used to classify. So I made a diagnosis of schizophrenia, and based on predominant symptom, we would give a subtype. So agar my patient is having predominant negative symptom na, so that subtype was called as simple schizophrenia. And you can say, sir, negative symptoms have poor prognosis. Simple schizophrenia in fact has the worst prognosis. But abhi kya hai, we have removed this subtype. We say don't give any subtype, just call it schizophrenia. Okay, but remember, they may just give you patient ko delusions hai, hallucination hai, and they may just ask you the subtype. So then you will call it as paranoid schizophrenia. Now let's discuss, beta, catatonic symptom. This is a very important topic. Please highlight this in your notes. This is a very, very important topic which now we are going to discuss. Beta, catatonic symptoms. These are, beta, motor signs and symptoms. Sometimes you will see that in schizophrenia, patient may develop some of these motor signs and symptoms. But please remember, beta, we are discussing catatonic symptoms here. It does not mean it is only seen in schizophrenia. In fact, remember, it is more common. These catatonic symptoms, beta, in fact, remember, are more common in mood disorders than even schizophrenia. So even in other conditions also, they can occur. But since we are discussing schizophrenia first, beta, let's discuss these catatonic symptoms. And you will see in the exams, they have asked questions just from these symptoms also. So let's discuss some of these motor symptoms, signs and symptoms. First is, beta, stupor. What do you mean by stupor? Beta, stupor means decrease in the psychomotor activity. So patient, beta, psyche means mind, motor means body. So there is significantly reduced psychomotor activity. So you will see that the patient is just lying down on the bed. Hardly patient is speaking, hardly he is moving. So this is stupor. But sometimes in neurology we use a term for this stupor. What is the term we use? That is akinetic mutism. So again, meaning the same. Akinetic means the movement is less, very significantly reduced, and mutism, he is also speaking less. So this is stupor. So sometimes you will see patient with catatonia may be having stupor, and you may see sometimes the person may even have excitement, beta, increase in the psychomotor activity. So you may see sometimes the patient is running around, removing cannula, catheter. So there is increase in the psychomotor activity. Next is beta mutism. Beta, what is the meaning of this term mutism? So sometimes when you are watching television, beta, you can mute the TV. So the screen is moving, but you cannot hear anything. So as if I have muted the patient. So there is significantly reduced verbal output. So there is significantly reduced verbal output. Patient is not speaking. Very good. So first three symptoms we have discussed, beta: stupor, excitement, mutism. Now let's see this image, beta. Sometimes they may just give you such images. Can you appreciate patient may maintain such odd posture? Now what is this term? So patient may maintain a very odd posture. It could be two important terms, remember beta. One is catalepsy. Again, don't confuse catalepsy with cataplexy. Beta, cataplexy, where we will discuss in a sleep disorder, narcolepsy. How to remember? Beta, remember it like this, कि narcolepsy में we don't get catalepsy, we get opposite, we get cataplexy. तो catalepsy कहाँ मिलता है? In catatonia. So catalepsy and posturing, beta, both mean that patient has maintained a very odd posture for a long duration against gravity. But if they ask you the difference, beta, what is the difference? Remember, catalepsy is a passive phenomena. Suppose the examiner made the person stand like this. So patient himself did not come into this posture, but somebody else made him stand like this. Now he is maintaining it. So ये क्या है? Catalepsy. While remember beta, posturing is a active phenomena. Suppose patient himself came into this posture and now he is maintaining it. So then we'll call it as posturing. Is it clear to everyone, beta? हाँ, very good, beta. Next, let's discuss, beta, next very interesting term. And so many times they may just ask you about such terms. One is waxy flexibility. But what do you mean by waxy flexibility? See, the name is telling you, flexible like a wax candle. So please see, for example, can you appreciate, suppose this is a wax candle. If I try to bend this candle, there will be initial resistance and then I can bend the way I want. So this is the meaning of waxy flexibility. The person can be bended. So bending like a wax candle. Okay, bending like a candle. But can you also appreciate, beta, please remember one more important point, that there is initial resistance. Let me discuss two patients A and B. Beta, please see here everyone, very good. Please see here everyone. Patient number A, I took his hand, there is no resistance, I made his hand into this posture and now I released my hand. Beta, patient has maintained this posture. What is this phenomena? Can I say this is catalepsy? Patient number B, I took his hand, beta, there is initial resistance and after that I am able to bend the way I want. And when I released my hand, beta, slowly patient's hand came down. ये क्या है बेटा? This is waxy flexibility. Remember, there is initial resistance in waxy flexibility, bending like a wax candle. I hope this is clear to everyone. Let's now discuss the next two symptoms better together. So very easy if you just see the name. So next is negativism. Better just see the name. Negativism, as if the patient is having a very negative attitude towards the examiner. So the person is opposing, he is showing he is opposing or he is giving no response. Whatever I am saying, he is opposing it, doing opposite. I ask the patient to come forward, the patient goes backward. I ask the patient आगे आओ, patient और पीछे चला गया. So beta, can I say he is doing opposite or he is not moving at all? There is no response. So this is negativism. While what is automatic obedience, beta, this, as the name suggests, now the patient is extremely cooperative. So there is excessive cooperation. Beta, even if it is harmful for the patient, he will cooperate. For example, I ask the patient that, I tell the patient that I have a needle and with this pin, in fact, I will prick your tongue. तो मैंने patient को कहा ये. Now I ask the patient to pull out the tongue. But a patient will pull out the tongue. Even if I slightly prick his tongue with this pin, he will again pull out the tongue if I ask. तो अब क्या हो गया बेटा? Patient is automatically obedient. So this is automatic obedience. But the next two phenomena, let's discuss them together. One is mannerism and another is stereotypy. Beta, both mean that there is a repetitive odd movement which the person is doing again and again. But what is the difference? Beta, again, the difference you can remember in the name itself. Beta, the word mannerism is made from manner. Na? Here, whatever movements he is repeating, beta, these have a purpose. These are purposeful movements. For example, beta, patient is doing this. What is this? Can I say this is salute movement? It has a purpose, but now it has become odd repetitive. So this is what? This is mannerism. While stereotypies, remember, these are non-purposeful movements. These are non-purposeful movements. For example, a patient is doing such movement, hai na? There is no purpose. So these are stereotypies. Let's discuss the next two symptoms together, beta. One is echolalia. So echo is to repeat, lalia means word. So here the person is repeating words. So he is repeating words. Whatever he is hearing, he is repeating. In fact, beta, this came as a PYQ. So that is why I am saying you will see many questions like this. You ask a patient, what is your name? Patient says, what is your name? What do you do? What do you do? Where do you live? Where do you live? So can you appreciate here, whatever he is hearing, he is repeating. What is your name? My name is Mukesh. What do you do? My name is Mukesh. Where do you live? My name is Mukesh. Now can you appreciate here? Initially it was relevant, now he is repeating beyond the point of relevance. वो क्या था? वो था perseveration. Beta, now this is clear to everyone. Na? Somebody was asking, sir, echolalia और perseveration में क्या difference है? Echolalia, whatever he is hearing, he is repeating that. While in perseveration, initially what he said was relevant, now that same thought is repeating beyond the point of relevance. Right? And beta, what is echopraxia? See, we have discussed now, what was apraxia? Praxia का मतलब movement. So echopraxia, very simple now. Echopraxia क्या हो जाएगा बेटा? There will be repeating, or you can say mimicking. Now the person is repeating or mimicking the movements. So he will copy the movement. Suppose you have a pen and paper, you are writing in front of the patient, but a patient does not have any pen and paper, he will also copy your movement. Start scratching your head in front of the patient, patient will also start scratching his head. So ये क्या है बेटा? This is echopraxia. Let's discuss the last two symptoms, then we'll discuss beta treatment of catatonia here only. Beta, what is grimacing? Nowadays, beta, when you take a selfie, what do? You pout. If you maintain that pout for a long time, that is known as grimacing. So what is grimacing? Grimacing means maintaining odd facial features, maintaining of odd facial features. So sometimes you will see that patient with schizophrenia may maintain such odd facial expression. So this is grimacing. And the last is beta ambitendency. See this. We have already discussed beta what was ambivalence. Ambivalence was inability to decide at the level of thinking. Beta, this is tendency na. So here inability to decide a movement. For example, beta, there is a pen on the table and the person is staring on this pen for hours and hours, thinking in his mind कि इसको pick करूँ या ना करूँ. तो बेटा ये क्या हो गया? This is ambivalence. He takes his hand forward, then backward. Takes his hand forward, then backward. Not able to decide the movement. Should I pick or should I leave it? So ये क्या हो गया बेटा? This is ambitendency. So these are some important, right. So please remember beta, these are some important catatonic symptoms. Now when we say that person has catatonia, see, but I've given you some space now, write down when do we say that person has catatonia. Should all the symptoms should be present? No. We say if a person has 3 or more symptoms out of these, then we say that patient has catatonic symptoms. Now here only beta, let's discuss, this is again a very important point, please highlight this. Very good. Beta, what is the treatment? A person comes in the emergency, he is maintaining this posture, let us say for so many days, he is having echolalia, there is waxy flexibility, he is not eating much. You give him one injection and within few minutes the patient comes to the normal position, says please give me food, I am hungry. What is this injection you have given, or what is the first line treatment beta? Very good beta, please remember first line treatment is we can give benzodiazepine like lorazepam, we can give parenteral like IVIM or even oral. If I ask you beta is the best treatment beta, this is the first line. What is the best treatment if it is asked? Benzodiazepine is not working beta, what is the best management? So then we can take the patient to OT, give him anesthesia, give him muscle relaxant and we pass electric current, patient develops seizure. Beta, what is this? This is ECT. If they ask you best, then you can say electroconvulsive therapy. So we are using electric current to produce convulsion. Very good. So is it clear to everyone? So here only beta, we have also discussed some important points about the management. Let's now discuss the diagnosis of schizophrenia. Okay. So the diagnosis of schizophrenia beta, in DSM-5 we have 5 symptoms of schizophrenia which we can remember from the name of the movie Dhadkan. Don't worry if you have not watched the movie, in the movie nobody had schizophrenia, but from the name we will remember the symptoms. So remember D for delusion. So now we know any delusion can occur in schizophrenia beta. HA for remember hallucination, any hallucination can occur. D for remember disorganized speech or disorganized thinking like loosening of association, like tangentiality, derailment. K or C you can remember catatonic symptom, and N for remember negative symptom. So these are the 5 symptoms of schizophrenia. Okay, and I also given you a trick. Now what is the diagnostic criteria beta? If I ask you, DSM-5 says how many symptoms should be present? So please remember that out of these 5, at least 2 or more. So out of the 5, 2 more symptoms. So please remember beta, out of the 5 कितने symptoms होने चाहिए? 2 or more, but there is a catch. At least 1 symptom should be from first 3. So beta, what are the first 3 symptoms? Remember delusions, hallucination, disorganized speech. इनमें से कम 1 symptom होना चाहिए, and minimum number of symptoms should be 2. At least for 1 month, but total duration of disturbance beta for making a diagnosis in DSM-5 should be कितना? Please remember it is 6 months. Okay, please remember. So what I am trying to say, see, overall total duration of illness should be 6 months, and in this 6 months, at least for 1 month, this criteria is getting fulfilled. In remaining months, the person may have 1 symptom, may have residual symptoms, disturbance may be less. So total duration is 6 months, please remember. So very important, because please remember beta, what is the duration in ICD-11? If I ask you duration of ICD-11 beta, what is the duration? In ICD-11 the duration they use is 1 month. If nothing is mentioned beta, then you can go with the duration of DSM-5. Or if they specifically ask you according to ICD-11, then you can go with 1 month. Is it clear to everyone beta how to make a diagnosis of schizophrenia? This is very important, right? So let me show you one question. Let's discuss one question. You have to tell me the diagnosis here. See, please try to identify keywords. Whenever you are anticipating or you're practicing MCQs, always try to identify keywords. A 20-year-old male claims since 8 months that his college principal along with some teachers are planning to fail him and want to expel him from college. He complains they also continuously talk about him, which he is able to hear even at his home. He has stopped going to college and says that he will take revenge from his college people. His friends haven't noticed anything like this. They try to convince him. He's not getting convinced. His self-care has also deteriorated. Beta, can you tell me what is the diagnosis here? Can you tell me beta, what is the diagnosis? Very good. So see, the green symptom, can I say he is having a false belief? It is which delusion? Delusion of persecution. What is this beta? He can hear the voice even at his home. So here they are trying to tell you that auditory hallucinations have developed. And what is the duration beta? 6 months or more. So can I say at least 2 symptoms are present and both the symptoms are from first 3. So yes, we can make a diagnosis of schizophrenia. Very good beta. We can make a diagnosis of schizophrenia. But also, can you appreciate what is this? He has stopped going to the college and also self-care has deteriorated. Can you tell me beta, what is this? See, whenever we say that somebody has a disorder, we say that symptom criteria is getting fulfilled, duration criteria is getting fulfilled. One more important point beta, which we usually discuss is functional impairment. Can I say that functioning of the patient is also getting affected, such as his occupational functioning, like he has stopped going to the college. Even social functioning may get affected beta, even his self-care may get affected. See, whenever we say somebody has a disorder, even we say that functional impairment is also there. Some disorders may have less impairment, some may have more, but also we say that there is impairment in functioning. This may be given in the MCQ, may not be, but are you able to make the diagnosis now? Very good beta. Patient oriented hoga beta. Schizophrenia you will see patient is oriented, right? Clear to everyone? Everybody will be able to now make a diagnosis now. Such question has been asked beta. Again, you will see a similar question you will see in the PYQs. Such question has been asked in your exam, okay, to make the diagnosis, okay. Let's now discuss the management. So let's discuss some important points about the drugs. See, schizophrenia beta kya hai? It's a psychotic illness. So we are using antipsychotics. And we have 2 important categories. One is the first generation beta or the typical antipsychotics, and we have second generation or the atypical antipsychotics. Beta, what is the mechanism of action? Can you appreciate? We were saying the dopamine is getting increased. So the mechanism of action of first generation is beta, they are which dopamine receptor antagonist? Especially remember it is D2. We also said that even serotonin bhi beta increase ho raha hai na. So what is the mechanism of action of second generation? Remember it is not just 5D2, also 5HT2. See, dono 2 hai, D2 and 5HT2. Remember A for which 2? A for remember atypical. So it is D2 and 5-HT2A antagonist. Is it clear? Now also let's discuss few more points. Very good beta. Let's discuss few more points. We know that EPS, extrapyramidal symptoms, it occurs because of D2 antagonism. So usually which drug have more EPS? Please remember, second generation have less EPS, first generation usually have more EPS. Okay, we'll discuss about the EPS point, we'll discuss that table of EPS, very important. But also we talk about metabolic syndrome. But metabolic syndrome means patient may develop weight gain. Patient says, sir, I am gaining weight since this drug has started, or patient may develop increased blood pressure, patient may develop dyslipidemia, patient may develop, there may be cardiovascular disease, okay, there may be diabetes. So these are metabolic side effects which can occur of these drugs. And metabolic syndrome, beta, one of the important mechanism, beta, kya hai? We have discussed this point also, na? Tell me, one of the important cause of these metabolic syndrome is 5-HT, remember 5-HT2C antagonism, very important, antagonism. Okay, this is because of 5-HT2 antagonism. And how to remember beta? See, it is metabolic na, remember 5-HT2C. And again, how to remember? We know serotonin is more blocked by the second generation. So remember, in general, the metabolic side effects are more with the second generation as compared to the first generation. But of course, there are some exceptions which have been asked in your exam. So I'll discuss those questions also. 2 questions recently beta came just from this metabolic syndrome wala topic. We'll discuss. Also, can you appreciate beta? Please see this. We are saying that first generation is only D2 antagonist, so it is having effect more on positive symptom, while the second generation is affecting also the 5-HT2 antagonism. So we discussed serotonin increase होने से दोनों हो रहे थे positive और negative symptom. So it is effective for both positive and negative symptom. So please see this beta. This is a very important table. Please try to remember some of these points. Let me know if it is clear to everyone. Then I'll discuss a very important table, that is EPS. So let's now finally discuss beta EPS. This is, please highlight this in your notes. Please highlight, हाँ बेटा, we'll discuss examples ना, अभी EPS के examples I'll discuss. Nearly in every exam you're seeing questions on EPS, so this is a very important table. So patient, they may give you in the history that patient is on some antipsychotic D2 antagonist drug, and patient may develop some motor symptoms or motor side effects. How we have learnt the EPS beta? We have learnt with the mnemonic na, DP at night, है ना? So there is dance party in the colleges, so DP at night. So what is D? Beta D से क्या है? Dystonia. There is a sudden contraction of a group of muscles. So, and in fact it is one of the earliest EPS to occur. So this is acute dystonia. Sometimes maybe within few minutes, within few minutes you gave one injection, antipsychotic injection, patient may come to you like this. So my neck is twisted to one side, I am not able to move the neck. So this is what beta torticollis. Patient says my eyes are uprolled upwards. So this is what oculogyric crisis, or there may even be laryngospasm. Patient is not able to swallow, is not able to speak. What is the treatment beta? Patient may come in the emergency. What is the treatment? Remember, in the treatment we give anticholinergic drugs, especially we can even use parenteral drugs like benztropine, promethazine. So please remember, they may give you a clinical presentation, they may ask you the management. Also remember beta, this question was asked that patient had developed acute dystonia for which a drug was given, and after giving that drug the patient developed dry mouth, there was blurred vision, urinary retention. But can I say we might have given, must have given patient anticholinergic drug like benztropine, and it can cause anticholinergic side effects also, no? So the answer was, which drug was responsible? It was benztropine. Okay, so this is D for dystonia. Beta, what is P? P for remember Parkinsonism, drug induced Parkinsonism. So a patient on antipsychotic comes to us like this, I am having tremors, there is rigidity, there is bradykinesia. Again beta, what is the treatment? Very good beta. Treatment is, again we will give anticholinergic drugs, even oral drugs like trihexyphenidyl can be given. But sometimes what happen that after long-term use, so a patient is on antipsychotic for a long duration, there may also be some other manifestation of this drug-induced Parkinsonism. You may see perioral tremors, you know, sometimes you will see such vertical tremors like this, and these are known as, this is known as beta rabbit syndrome. Very good. And this came in the recent FMG exam as one of the image based question. So they had given a image of a rabbit, they had given a history of patient on antipsychotic, has developed perioral, tremors. So this was what? This was rabbit syndrome. Please remember this, beta. Please remember this point. हाँ, very good. DP at बेटा A से क्या है? There is akathisia. What is akathisia? बेटा akathisia का मतलब है restlessness. In fact, this is the most common EPS. Patient is very restless. So patient will tell you, sir, ma'am, I am feeling very restless from within. मुझे बहुत घबराहट हो रही है. I am feeling very restless. And objectively बेटा जब आप बाहर से भी patient को observe करोगे, you will see patient is continuously moving. He is not able to stay still. He is pacing around in the ward. So from inside and outside both he is appearing restless. So this is akathisia. And what is the drug of choice beta? We can give beta blockers like propranolol. DP at beta T से क्या है beta? What is T? T is tardive dyskinesia. See, tardive means long term use. Again in the history they may give you that patient is on antipsychotic maybe for months or years. And dyskinesia मतलब beta patient has developed some abnormal movements like there is lip smacking or chewing movement like this, or tongue protrusion movement, or on the hand you will see coriform piano playing like movements, or even pelvic thrusting movement. So what you have identified, this is tardive dyskinesia. But don't confuse this with rabbit syndrome. Rabbit syndrome you will see perioral tremors. So don't confuse this, okay? And what is the treatment beta? We can give VMAT2 inhibitors, that is vesicular monoamine transporter 2 inhibitors like valbenazine, deutetrabenazine. And the last is DP at night, beta N for very important neuroleptic malignant syndrome or NMS. Beta if I say something is malignant, that means it is benign or it is serious. It is a serious condition, very important. It's a life-threatening condition. So a patient on antipsychotic or a dopamine antagonist drug comes in the emergency beta with high temperature, increased CPK, creatine phosphokinase levels is increased. There is muscle rigidity. Patient may also have other symptoms like sweating, increased blood pressure, confusion, even the TLC count may be increased, even the liver function test may be deranged. So what you are suspecting beta, you are suspecting NMS. So please be very careful, sometimes such emergency situation may also be given. So there are two important questions beta. If I ask you what is the first step, see there are two different questions beta. If I ask you what is the first step would be to stop antipsychotic. And if they ask you beta what is the drug of choice, then you can say dantrolene, okay, skeletal muscle relaxant. Even dopamine agonist like amantadine, bromocriptine, these can also be used. Okay, so this table is very important beta. Please remember DP at night. So we have discussed some important points about these EPS. Okay, please be very careful, read the question carefully, identify this and also identify the management. Okay. Okay, then beta yes, then we can use other drugs also beta. Then we will see even other drugs, antagonist drug that can be used, but here I am saying drug of choice. Okay, sometimes other drugs like benzodiazepine, these may also be useful, but we are talking about the drug of choice. Okay. Now see, let's discuss few points beta about these drugs separately. So I'll discuss few more points about these drugs. So let's discuss some points about the first generation antipsychotics beta. One is chlorpromazine beta. This is the first generation antipsychotic. And what is the mechanism of chlorpromazine beta? Chlorpromazine, we know it is a D2 antagonist. But very interestingly beta, it also blocks some of the other receptors. It also blocks muscarinic receptor, alpha receptor and even H receptor. H is histaminic. So beta agar muscarinic receptors block honge, so can I say because of blockage of these receptors, patient may develop side effects. So if M receptors are, very good, it's a low potency drug. If muscarinic receptors are blocked beta, what would be the side effect? Anticholinergic side effect. So patient may report of there is blurring of vision, dry mouth, urinary fecal retention. Alpha receptors are blocked beta, then person may develop hypotension. If histaminic receptors are blocked, so person may report of sedation. And one more important point beta, because of this blockage of the histaminic receptor, patient may also report of weight gain. Very important point beta. Can you appreciate, we discussed that weight gain usually was more with the second generation, but there are some first generation like chlorpromazine, which is one of the drugs in first generation category, which also has a moderate risk of weight gain. And this question beta is a PYQ. We'll discuss this point, but please remember chlorpromazine is a first generation antipsychotic which has a moderate risk of weight gain. Also let's discuss beta one new question. They may just give you an image based question or an integrated question with opthal, that a patient is on antipsychotic comes with the emergency with deposits on the cornea and on the lens. Beta, they may also give you such images. So can you tell me? Very good, beta. Can you tell me which is the drug? C, please remember C for chlorpromazine, C for corneal and lenticular deposit. So these are some important points about chlorpromazine. This question was asked in INI-CET exam. Chlorpromazine blocks D2, alpha, H, M, all. So answer was all. D2 is the mechanism of action and rest blockage is causing side effects. Let's discuss beta one more drug, that is thioridazine. Again in the name beta R is coming now. What is one important ocular finding associated with thioridazine? Remember, it can cause retinal pigmentation. Also remember R for rise in the QT interval. Okay, so this is thioridazine. Haloperidol beta, out of the first generation of antipsychotic which has maximum EPS, beta remember haloperidol has maximum EPS. So these are some drugs in the first generation category beta which we have discussed. Also, can you appreciate, see what was the treatment of acute dystonia, or what was the treatment of drug induced Parkinsonism? Tell me what was the treatment. You will say, sir, we used anticholinergic drug. And can you appreciate chlorpromazine itself also has anticholinergic properties. So please remember, drugs like chlorpromazine also, they can cause EPS, but again they have usually less potential of causing EPS. Very good. Is it clear? But out of the first generation beta which is having maximum EPS risk, that is haloperidol. Let's now discuss beta some important drugs in the second generation category. One is olanzapine. Again this question was asked in your FMG exam. A patient is developing schizophrenia, started on olanzapine and he showed improvement, but the patient stopped taking the drug. Can you tell me one important reason which could be because of which side effect patient might have stopped taking the drug? Beta, please remember O say olanzapine or O say obesity, or you can remember weight gain. Very good. But again this is a PYQ. Okay, so they may ask such questions again. So please be very careful. In fact, there are two drugs beta which have high risk. Two drugs beta which have high risk of weight gain in the antipsychotic category beta. One is clozapine, we will discuss, and another is olanzapine. Okay, olanzapine. Risperidone, see risperidone second generation hai, but out of the second generation one of the drug with high risk of EPS beta, please remember again it is risperidone. So risperidone is one of the drugs with high risk of EPS. But also remember, because of D2 blockage, EPS can occur, and also one more important side effect. Can anybody tell me an endocrinal abnormality which can also occur because of D2 antagonism? But this again may come as a new question, so that is why I am discussing. Please tell me, can you tell me an important endocrinal abnormality? But please remember hyperprolactinemia. Very good. Hyperprolactinemia. Very good. Please remember. So a young female, 20-year-old, 25-year-old female on antipsychotic, she is not pregnant, not delivered any baby, but comes to you with complaints of galactorrhea, milk secretion from the breast, or is reporting of amenorrhea. So this could be because of hyperprolactinemia. So very, very careful one has to be. See, please remember this. Okay. Now aripiprazole has been asked previously in the exam. So the question which was asked earlier was, can you tell me what is the mechanism of action beta? Very good beta. Please remember it is hyperprolactinemia. What is the mechanism of aripiprazole beta? Please remember it is a partial D2 agonist. Again acting on D2 receptor, but it is also a partial D2 agonist. And we will also discuss about ziprasidone beta. Aripiprazole and ziprasidone, you can remember it with this trick A to Z. So we have learnt with this trick na A to Z. So there are some second generation antipsychotics beta, two important ones you can remember, A to Z, which have low risk of weight gain. So please remember this point. In fact, this question came in your exam. Both aripiprazole and ziprasidone, remember they have low risk of weight gain. So they asked which of the following drug has least risk of weight gain. Beta chlorpromazine bhi tha option mein and ziprasidone bhi tha. Ziprasidone although is second generation, but it has low risk of weight gain. But one side effect you can remember, it can also increase the QT interval. Also remember beta with aripiprazole na, it is one of the drugs which have low risk of hyperprolactinemia. So it is one of the drugs with low risk of hyperprolactinemia. So remember this point as well. Very good. Now let's discuss one very important drug beta, that is clozapine. So again please highlight clozapine. clozapine is again a second generation antipsychotic, but when we see the mechanism, beta, it is affecting D4 receptors more than D2. और EPS हो रहे थे because of D2 blockage. So please remember, in the second generation, it is one of the drug which has less EPS. But can you tell me what is the use, one important use of clozapine? Suppose a patient comes to us for the first time, he has developed schizophrenia. Never ever before he has been started on any antipsychotic. Can I start this patient for the first time with clozapine? Yes or no? Tell me yes or no. Very good. But so many important points you are answering in the chat box. Very good. Please remember, it is used for treatment resistant schizophrenia. So if there is no response, very good. If it is showing no response to at least 2 antipsychotics beta, then we will consider giving clozapine. Why? Because we know it has some serious side effects. So I'll discuss some serious side effects, but very good. Also please remember, clozapine is one of the drugs which also has anti-suicidal property. I'll give you a list of some of these drugs with anti-suicidal property. One of the drug, remember, is clozapine. So what are the serious side effects beta of clozapine which we have discussed with the mnemonic SAM, right? So one is seizure. So patient on clozapine, he has developed seizure. So beta, what we can do in the treatment, we can treat the patient with anti-epileptic drug and then again we can restart the clozapine. Next is very important beta, agranulocytosis. So this is one of the serious side effects, agranulocytosis, that is decrease in the WBC, especially the absolute neutrophil count. So patient on clozapine, beta, please listen to this clinical scenario. Patient on clozapine comes to us with fever, sore throat, tachycardia. So we are suspecting some infection. What you need to do? Check the counts. Beta, stop the drug if the counts are reduced. Very, very important. So they may also give you such clinical scenario as well. In fact, beta, ये इतना serious side effect है. Very good, beta. It's such a serious side effect that we monitor. I mentioned this in the workbook also, beta. We monitor these counts for the first 6 months. Every week we check. Next 6 months, beta, every 2 weeks, and then every month we check these counts. So this question was asked, beta, in one of the INI-CET exam. Which serious side effect of clozapine requires close blood monitoring? So beta, क्या था answer? Agranulocytosis. And even myocarditis can occur, beta. Myocarditis patient on clozapine comes to us with chest pain, abnormal ECG, tachycardia. So again, in myocarditis, we may have to stop the drug. Now give me the answer of this FQ, beta. Again, FQ, future question, some new question I'm discussing. Suppose a patient on clozapine has developed seizure. We are planning to start some anti-epileptic drug. Tell me which important drug is contraindicated with clozapine. Tell me which important drug is contraindicated beta with clozapine. Very good, yes. Yes, CBC, you are getting checked. So please remember beta, कौन सा drug है? C से contraindicated, C से clozapine. It is very good. It is carbamazepine. Carbamazepine. Okay, because we read in pharma that it can cause bone marrow suppression. So again, it's a lethal combination. So don't start a patient who is on clozapine, another drug which also decreases the counts. Yes, clozapine beta can also cause some other side effects such as sedation. It can cause sedation, even cyalloria, remember, excessive salivation. Ask the patient to put a towel over the pillow before sleeping. So patient says, sir, my pillow is all wet when I wake up. This is because of decrease of swallowing. So one practical step is ask the patient to put a towel over the pillow. Also remember beta, C for clozapine, it can also cause constipation. C for constipation. Okay. So these are some but commoner side effects. Okay. So these are some important points about clozapine. Let me show you one question beta. This is clear to everyone now. So see in the question what drug they have mentioned. Try to see the clinical picture and then answer the question. Okay. Let me see if we can now answer this question beta. Now this becomes very simple now. Let's see if we can answer this question. Antipsychotic with least metabolic effects. These three are second generation, this is first generation. But still, you know, we know it's not the answer. Hai na? Quetiapine is also a second generation. It also is associated with side effect like cataract. Okay, some ocular finding. Very good beta. नहीं देखो आंसर बेटा लीस्ट पूछा है ना, अभी हमने डिस्कस किया ना, अभी हमने डिस्कस किया नहीं बेटा, फिर से देखो, इट इज नॉट, आंसर इज नॉट डी. क्लोरप्रोमाजीन तो मॉडरेट रिस्क कर रहा था ना. विच ड्रग वी डिस्कस्ड हैविंग सम सेकंड जनरेशन ड्रग आल्सो वी डिस्कस्ड विच हैव लो रिस्क. हाँ, वेरी गुड बेटा. आंसर इसमें क्या है? इसमें आंसर इज ज़िप्रासिडोन. इज इट क्लियर टू एवरीवन? सो प्लीज रिमेंबर अ लॉट ऑफ क्वेश्चंस हैव बीन आस्क्ड फ्रॉम दीस साइड इफेक्ट्स. ओके. Risperidone also again has a moderate risk. Okay. So remember, low risk wali first generation, second generation we have discussed, and many of the first generation also have low risk. Okay, but we have discussed ये moderate risk है, और second generation में remember aripiprazole, ziprasidone they have low risk. Okay, and highest risk बेटा कौन सा था बेटा? High risk वाली कौन सी दो drugs थी हमने discuss की? Remember clozapine and olanzapine. Okay, it's okay. You don't just have to be very careful next time. ठीक है ना? Doesn't matter now. Let's discuss बेटा one more drug we'll discuss. See, we have discussed ना that देखो etiology में can you appreciate we have been discussing कि acetylcholine has reduced. So now there is one more new drug, but again, so let's just update about this one new drug. At least remember the name, remember the mechanism. So we have xanomeline. So remember M is coming in between, na? It is M1, M4. See, in the etiology we said कि acetylcholine is reduced. So if we are targeting a drug which is affecting these muscarinic receptors, so we are using an agonist. So it is a M1, M4 muscarinic acetylcholine receptor agonist. So remember the name that is xanomeline, but it doesn't matter na. Just try to now remember. So that is why I am showing you questions. So please be very careful. Questions on side effect of antipsychotic may be asked. Lastly, beta, let's see the duration of treatment. Beta, suppose a patient comes to us with the first episode of schizophrenia. For the first time he has developed schizophrenia, and we started the patient on antipsychotic. So usually we can give beta any antipsychotic, but if they specifically ask you out of second and first generation, then you can remember second generation is preferred in many guidelines over first generation. But of course, see the question, suppose they say in the question patient is obese, then choose the drug which is having less side effect of weight gain. So that is how sometimes you have to choose the drug. So we chose a drug, we started the patient on treatment, and within a month, let us say, he showed improvement. Now if I ask you, beta, should I stop the drug? You will say no. But then the next question of the family members, for how long should I continue? Remember, beta, first episode mein you have to continue the drug for at least 1 to 2 years. If they ask you minimum, then 1, but agar 1 or 2 dono option mein, then better answer would be 2 years. Now suppose patient develops schizophrenia again. Now it is second or more episode. Beta, now for how long should I continue the treatment? Don't say lifelong. Okay, please remember it is 5 years, or you can say indefinite. Okay, or you can say indefinite. Okay, so this was about the duration. So we have talked about beta schizophrenia. The topic was psychotic disorders. One psychotic disorder we have covered, that is schizophrenia. Let's now discuss some other psychotic disorder. See, so what is acute psychotic disorder? See, suppose if a patient comes to us, with 5 days history, with 5 days history of delusion, hallucination. But can I make a diagnosis of schizophrenia? Yes or no? Even according to ICD-11 also I cannot make a diagnosis. So should I say the patient go back home, come back after 6 months? No. Of course I'll make a diagnosis na. तो क्या diagnosis बनाएंगे बेटा हम? We'll make a diagnosis of acute psychosis. Acute means less duration. If the symptoms are similar to schizophrenia but the duration is less, so then we will make a diagnosis of acute psychosis or acute psychotic disorder. But very interestingly, sometimes you will see that acute psychotic disorder may be preceded by a stressor. Maybe at the onset there is a stressor, like a psychological stressor. Beta कोई negative life event हुआ घर पे, let us say there is some death, somebody lost money, and even remember, even fever can also occur as a stressor. Very, very interesting. So let's write down one clinical scenario. Beta, this clinical scenario you will see in many situations, many Q banks and many questions you will see. Suppose a patient 5 days history of fever and patient has developed beta delusions and hallucination. Can you tell me 2 important differential diagnoses? Beta, one to you will say it is, sir, it could be acute psychotic disorder. Can you tell me one more differential diagnosis beta of this condition which we have discussed? Fever ki history hai, patient has developed delusions, hallucination. Very good beta, you may also think of delirium. So 2 important differential diagnoses. Beta, just tell me how will you differentiate? So in the question of acute psychosis, they may also give you delirium in the option or vice versa. But can you tell me how will you differentiate ki it is delirium or acute psychosis? Please remember, we have discussed that in delirium we know there is impairment of consciousness. Somewhere in the question they are trying to tell you that the consciousness is impaired. Then I am thinking of delirium. Otherwise I am thinking of acute psychosis. See, in DSM-5, the duration of schizophrenia was 6 months. So they further divided beta acute psychosis into 2 categories. One is brief psychotic disorder if the duration is less than 1 month. Another is schizophreniform disorder if the duration is beta more than 1 month but less than 6 months. If it is 6 months or more, then you will make a diagnosis of schizophrenia. And since it's a psychotic disorder, beta, what is the treatment? You will say we can give sir antipsychotics. Next question. Beta, please be very careful. Again, PYQs have been asked from acute psychosis, even from delusional disorder. See, the name delusional disorder is telling you, beta, delusional disorder means patient is having only delusion. Beta, can I make a diagnosis of schizophrenia if a patient has only delusions, one or multiple delusions? Yes or no? Tell me. Can I make a diagnosis of schizophrenia, beta? Can I make a diagnosis of schizophrenia with only delusion, beta? देखो adjustment disorder तो बेटा neurotic disorder वाली category है, वहाँ पे तो हम अभी तो हम delusions, hallucination, we are discussing about these symptoms. You will say no, no, because we know at least 2 symptoms should be present from the 5 symptoms. So if patient is only having delusions, beta, they may be related or they may be, maybe unrelated, but only delusions are present. Remember, hallucinations are absent, or if present, beta, they are transient, matlab they are not persistent. If they are persistent, my diagnosis would change to schizophrenia or acute psychosis depending on the duration. So if patient has only delusions, beta, then I am thinking of delusional disorder. Again, treatment mein we can use antipsychotics. Beta, this question was asked in your FMG exam. A father thinks my daughter wants to kill me. Diagnosis. So daughter wants to kill me, matlab delusion of persecution. Only one symptom was present, only one delusion was given. So then the answer was not schizophrenia, it was delusional disorder. Is it clear to everyone, beta? In fact, also write down one risk factor. This question was asked in NEET PG, so you can just have an idea about this. So usually we know that in schizophrenia, late onset has good prognosis. But remember, beta, delusional disorder may advanced age, as the age increases, the risk of delusional disorder may increase. So remember, in delusional disorder, advanced age is one of the risk factors. I hope this is clear to everyone now. So we have talked about a very important topic, that is psychotic disorders, right? Let's now discuss about the mood disorders. So we have discussed organic disorders, beta. We have covered psychotic disorders. Now we are going to discuss mood disorder. So mood disorder may there is abnormality, beta. This is a very important point. Let's discuss abnormality of mood. So please remember, the key point in mood disorder is that the mood is abnormal. So mood disorder also sometimes is referred to as affective disorder. Although we know the difference between what is mood and what is affect, we know, but we use this term interchangeably when we say mood disorder or affective disorder. So beta, mood can be abnormal in 2 ways. One is the mood may be very sad. So the mood is very sad, or the mood is very happy. Without any reason, the person is very happy. So either it could be sad or it could be very happy. But based on this, please understand this concept, then I'll discuss mood disorders. Based on this, beta, we have divided mood disorders into 2 important categories. One is very good. Beta, can you appreciate? So suppose this is, when the mood is sad, this is the lower pole. Here the mood is very happy, this is upper pole. In one condition, beta, you may see patient is having sad mood. Can you appreciate? It may be one episode or multiple, but the mood is always sad. So what is this, beta? We'll discuss. This is depression. This is depression. While on the other hand, sometimes the mood is sad, but sometimes the mood may be very happy. And what is this episode known as when the mood is happy, or sometimes it could be even irritable, we'll discuss. This could be mania or hypomania, beta, we'll discuss. So sometimes the mood may be sad, there may be also episodes in which the mood is very happy. So can you appreciate, beta? This is known as what? This is known as bipolar disorder. This is known as bipolar disorder. Why it is known as bipolar disorder? Because symptoms are present on both the poles. Kabhi khushi gum. So that is bipolar disorder. So remember this basic concept, then I'll move to what is depression, what is bipolar disorder. Also one more point, have you noticed here that usually you will see what is happening, beta, in between the person is becoming normal. So you will see that these disorders, they are episodic. So the symptom would occur for some time and then the person may have, the symptoms may remit. So whenever, beta, you are seeing any patient, so in the MCQ, beta, whenever they are telling you that patient currently is having, let us say, depression or mania or hypomania, always see, is there any past episode, because that will change the diagnosis. Is this point clear to everyone, beta? This is a very important concept, and now we will understand what is depression and what is bipolar disorder. Is it clear to everyone? Very good. But now let's talk about the first important disorder, that is major depressive disorder. In fact, this is a term for depression used in DSM-5, and many times you will see in the exams they have used this term. So they will tell you that patient is diagnosed with major depressive disorder. That means patient has depression. Also we can call it as bit a unipolar depression. Why unipolar? Because we can see that symptoms are present only on one pole. Is it clear to everyone better? Why unipolar? Because symptoms are present on both the pole, or you can just call it as depression. So in MDD, beta, patient is only having depressive episodes. Tell me, depression is more common in males or females? It can occur in both, but beta, if I ask you it is more common in males or females, remember it is more common in females than male. In fact, the ratio is 2:1. Let's first understand how to make a diagnosis of depression. Very good, beta. I hope you remember the mnemonic, beta. So to make a diagnosis of depression, beta, what is the mnemonic which we use? See, in depression, now there are two important set of questions they are asking. One is on specifiers and another is on management. In fact, abhi January maybe also beta they had asked a question, very simple question on the specifiers. So we'll discuss those questions. See, the mnemonic to make a diagnosis of depression we know is SIGE caps. Very good. So let us understand what are these symptoms, then I will give you the criteria. And a very interesting question was also asked from this criteria also recently. See, first is S. See, it's a mood disorder now. Remember, the first symptom is abnormality of mood. So let us say this 40-year-old female beta which we have been discussing, she says in the past 2 months, sir, wherever I am, most of the time I am sad. So S for the mood is sad or depressed mood. Second is interest. Beta, what happens to interest? We have already covered na, interest kam ho jata hai. And what is the term we use for decreased interest? Anhedonia. So it can occur. So SIGE, the mood is low, the interest is reduced. G, but a patient may have excessive guilt or worthlessness. So patient may have negative views about self. I am a bad person. So patient may have such negative views about self. But what happens to energy in depression? Energy is low. Patient says I get tired very easily. There is easy fatigability. So patient says, sir, nowadays even I am sitting, I get tired. So this is SIGE. But what is C? C for remember CAPS. CAPS में C क्या है बेटा? Concentration. The concentration is reduced. What was concentration we discussed now? That sustained attention. Patient says, sir, nowadays I forget things. So very interesting, this 40-year-old female says, sir, I am forgetting things. I forget where I have kept my important documents, important keys. But is it true dementia? No. This forgetfulness is actually because of decreased concentration. Beta. Suppose this pen patient had and patient kept the pen in her pocket. But patient was having so many thoughts in the mind, patient did not pay attention, the concentration was reduced. And now she thinks that she has forgotten. Actually, it is because of decreased concentration. In fact, remember one important term, beta. This may be asked. What is this known as? Is it true dementia? No, it is pseudo dementia. Very good. Okay, pseudo dementia. Okay, this is pseudo dementia. So pseudo dementia is seen in depression. So is it clear beta? CAPS, see, that is concentration is reduced. Beta, A for appetite. Very interesting, but again both can occur, decrease also increase. But usually you will see many patients says that the appetite has reduced. So what will happen to beta? Weight is also reduced. Patient says, sir, aajkal bhook nahi lagti. But sometimes patient may say opposite also. You know, in fact, you might have observed when you are very emotional, we go in the kitchen and start eating whatever is present. So appetite may increase, so there can also be weight gain. Both can occur, but usually more common is reduced in the appetite. P for remember psychomotor activity. So psychomotor activity can reduce beta. So patient is talking very slowly, is walking very slowly, but sometimes psychomotor activity beta can increase. So you will see sometimes patient with depression is very agitated, is very restless, both can occur. Then next is 2S beta. One is suicidal thoughts, acts can occur in the person. There may be history of suicidal attempt also, and sleep changes can also occur. Again, sleep changes may beta, there can be insomnia, decreased sleep, and some patient may even report of hypersomnia. I am sleeping a lot. So these are the symptoms, है ना? These are the symptoms of depression. Are all these symptoms beta clear to everyone? है ना? So beta, I've been told we will have this session on YouTube till 1:55. We will have this session on YouTube till 1:55, and then we will be switching on to the app. Okay. So I'm just informing this to everyone so that it is clear. So I've been told that till 1:50 we will continue this discussion on YouTube, and then we'll be switching to the app. Okay. Now let's discuss the diagnostic criteria beta. Can you appreciate that, let us say this is the first symptom and this is the second symptom. So the diagnostic criteria says that at least one of the symptoms should be present from first to, along with this 4 or more of the remaining symptoms should be present. So beta total number of symptoms कितने होने चाहिए minimum? Can you appreciate beta total number of symptoms should be 5. And for how much duration beta, can you tell me? Can anybody tell me beta what is the duration? What is the duration for how long the symptoms should be present to make a diagnosis? Very good beta. Please remember minimum duration is beta 2 weeks, that is 14 days. So then we can make a diagnosis of depression. Is it clear? So we have discussed how to make the nahi beta, not 1 month, it is minimum duration is 2 weeks. Yes, when we say weight change, very good beta, weight change mein matlab 5% change hai, weight change matlab 5% change, increase or decrease, okay, in a month. Is it clear to everyone beta? Now the question which was asked, now please see, that is why I am saying beta, if they are asking newer questions, na, the questions are asked again from the same concept. See, the question which was asked in your exams was, what is the key feature of depression? Beta, options were sad mood, let us say, decreased interest, suicidal thoughts, decreased sleep. Can you tell me? Can you tell me beta, if this question, you know, this question was asked in the FMG exam. So which is the key feature? Sad mood, decreased interest, suicidal thoughts, या decreased sleep? Tell me beta. Tell me. So the answer would be what? See, in the, beta, please always remember the criteria. See, the criteria is telling you, know, first 2 are very important. And I've been telling you, beta, it's a mood disorder. The key feature is abnormality of mood. So can I say, yes, beta, please remember sad mood. See, if sad mood was not given in the option, then you could have then gone for decreased interest. So sometimes you have to answer the question. Please always remember these criteria. That is why I told you, if you remember, in that schizophrenia SFRS wala question I told you na about hallucination, they may ask you that question also. Is it clear? Let's discuss some important points now. Beta, we have understood how to make a diagnosis of depression. Let's discuss some important specifiers. Beta, one is major depressive disorder recurrent, or sometimes also known as recurrent depressive disorder. In fact, this question again was finally asked in your exams beta. So can you appreciate what do you mean by recurrent depressive disorder beta? In recurrent depressive disorder, patient is having 2 or more episodes of depression. So in RDD, recurrent depressive disorder, we are saying that patient has 2 or more episodes of depression. Let's make one diagram beta. Let's try to understand. You have to tell me the diagnosis one by one. So I will use a lot of these diagrams beta. Tell me, a patient comes to us with this episode, what diagnosis you would make beta? What diagnosis would you make beta? You would say, sir, it is a depressive episode, so you'll call it MDD. Let us say after few months or few years, patient comes to us with another episode. So this question in fact was asked beta, patient comes to us with depression, and earlier also he was having a depressive episode. It is a depressive episode beta. Now you will see the entire picture na. Ab diagnosis kya banaoge beta? Now you will diagnose it as recurrent depressive disorder. Very good. In fact, remember, to call it as a new episode, we say for at least more than 2 months in between the person should be normal. This also is a very important point beta. Next time they may just ask you this question. So let me give you a clinical picture. You have to tell me, suppose a patient comes to us with depression. We started the patient on antidepressants, and let us say for 1 month beta, patient showed improvement. But again he developed the symptoms. Tell me now what diagnosis you will make. Let me see if we can answer this question beta. है ना? Please tell me now what diagnosis you will make. So can I say, now you will say it is MDD या RDD बेटा. देखो ध्यान से देखना नहीं, फिर से देखो. I am saying to call this as a new episode. In between, patient should be normal for at least 2 months. But in this clinical picture, I am saying after 1 month only the patient again develops symptoms. So will I consider this as a new episode or same episode? But this I will continue to assume as the same episode. So then I will continue to make the diagnosis of MDD. To call it as a new episode, the person should be normal in between for at least 2 months or more. Is this point clear now? So please be very careful, beta. Right? So now we are going to discuss the specifiers. And right, it is 1:55 now, so now we'll be switching. Again, thank you so much those who were on YouTube. Now we'll be switching to the app. So now we are going to discuss some important specifiers.